Welcome to your Q&A review for the WGU D313 Anatomy and Physiology 2 exam. We'll work through realistic exam questions, explaining why each answer is right, why others fail, and the physiology behind it. Today we cover Domain 1, the digestive system, including the 6 functions of the digestive system, the alimentary, canal, and accessory organs, the 4 layers of the GI tract wall, the peritoneum, mesenteries, and retroperitoneal organs, the enteric nervous system, and splanchnic circulation. Remember, our website offers free exam guides and practice questions designed to help you ace your D313 exam. Everything you need to study smarter and more effectively is right there waiting for you. Just check the link below to get started and take the stress out of your exam preparation starting today. Alright, let's get started. Question 1. A nursing student is tracing the path of a swallowed piece of bread and is asked to list only the structures that the bread itself physically passes through on its way from mouth to anus. Which structure should the student leave off that list? Your options are A. Esophagus, B. Cecum, C. Gallbladder, D. Oropharynx. Which one is it? Pause the video if you need more time. The correct answer is C. Gallbladder. C is correct because the gallbladder is an accessory digestive organ. It stores and concentrates bile and delivers that bile into the duodenum through a duct, but food never enters its tissue. The defining test for the alimentary canal is whether food physically travels through the structure. A is wrong because the esophagus is a segment of the alimentary canal that carries the bolus from the pharynx to the stomach. Swallowed bread passes directly through its lumen. B is wrong because the cecum is the first pouch of the large intestine and receives material through the ileocecal valve. Indigestible residue from the bread passes through it. D is wrong because the oropharynx is the region of the pharynx directly behind the oral cavity and is the first place the bolus enters after leaving the mouth. It is part of the continuous tube. The line between the alimentary canal and the accessory digestive organs is not about function, but about one simple physical test. If a swallowed bolus travels through the inside of a structure, that structure is part of the canal. If a structure only contributes a secretion or a mechanical push from outside, it's accessory. This split exists because a tube built to transport and resist abrasion is poorly suited to also running delicate chemical manufacturing. The plumbing makes the concept visible. Bile leaves the liver through the hepatic ducts, may be stored in the gallbladder, and travels down the common bile duct, while pancreatic juice flows through the pancreatic duct. Both converge and empty into the duodenum together, but the organs themselves never enter the food stream. The accessory roster includes the teeth, the tongue, 3 pairs of salivary glands, the liver, the gallbladder, and the pancreas. Teeth and tongue are the easiest to misfile since food constantly touches them, but food passes over and between them, never through them. Don't confuse accessory with retroperitoneal. One describes the relationship to the food stream, the other to the peritoneal membrane. The pancreas is both. The liver is accessory but intraperitoneal, and the ascending colon is retroperitoneal yet still unmistakably part of the canal. Question 2. During a small bowel motility study, a clinician observes localized ring-like contractions that repeatedly divide and redivide the intestinal contents, mixing them thoroughly with digestive juices while advancing them very little toward the colon. Which movement is being observed? Your options are A. Segmentation, B. Peristalsis, C. Mass movement, D. Retropulsion. Take a second. Which answer would you pick? The correct answer is A. Segmentation. A is correct because segmentation is the characteristic mixing movement of the small intestine during active digestion. Localized rings of circular muscle contract and relax repeatedly, chopping the chyme and bringing it into fresh contact with the absorptive surface. It mixes far more than it propels. B is wrong because peristalsis is a directional wave in which muscle contracts behind the contents and relaxes ahead of them, so its purpose is forward propulsion. The described contractions are not advancing the contents. C is wrong because mass movements are powerful sweeping contractions of the colon that occur only a few times per day and drive feces toward the rectum. They are not a small intestinal mixing pattern. D is wrong because retropulsion is the backward jetting of gastric contents against the closed pyloric sphincter during stomach churning. It occurs in the stomach, not the small intestine. 40 minutes after a meal, the duodenum isn't pushing food along in a steady march. Instead, rings of contraction pinch the chyme in two segments, release and reappear elsewhere, chopping the same material again and again. Segmentation exists because of a mismatch in timescales. Chemical digestion and absorption take time, but plain forward propulsion would move food through too quickly. So segmentation trades forward speed for contact time. Both patterns use the same circular muscle layer but organized differently. Segmentation fires at multiple isolated points with no coordination, while peristalsis organizes those same contractions into a traveling wave, and the mesenteric plexus decides which pattern runs. The rest of the family follows the same logic of location and purpose. Retropulsion drives stomach contents against the pyloric sphincter for grinding. Mass movements sweep the colon a few times daily. Haustral contractions slowly churn colonic pouches. And the migrating motor complex is the small intestines between meals housekeeping sweep. The real test is in appearance, since both involve rings of contraction, but net displacement. Eating a meal is a genuine physiological switch, flipping the intestine from housekeeping into mixing mode, and that switch is the key to sorting every term in this family. Question 3. An instructor asks a physiology class to explain the chemical basis of enzymatic digestion, noting that every step of chemical digestion consumes water. Which statement correctly describes what the digestive enzymes are doing to nutrient molecules? Your options are: A. They dehydrate large molecules until the bonds holding them together collapse. B. They dilute the chyme so that nutrient molecules disperse and become absorbable. C. They oxidize nutrient molecules and release water as a byproduct of the reaction. D. They split chemical bonds by adding a water molecule across the bond. Before I reveal it, which one do you think is right? The correct answer is D. They split chemical bonds by adding a water molecule across the bond. D is correct because chemical digestion works by hydrolysis, which literally means splitting with water. The enzyme catalyzes the insertion of a water molecule across a bond, breaking a polymer into smaller units and eventually into absorbable monomers. A is wrong because dehydration synthesis is the reverse reaction, the one that builds polymers by removing water. Digestion does the opposite of this. B is wrong because dilution changes concentration but breaks no bonds. A starch molecule diluted in water is still a starch molecule and still too large to cross the epithelium. C is wrong because oxidation reactions of this kind belong to cellular metabolism after absorption, not to the breakdown of food in the lumen. Digestive enzymes are hydrolases. Every act of chemical digestion, from your first bite of bread to the final breakdown of protein, comes down to one reaction: hydrolysis. Understanding this single mechanism unlocks the logic behind the entire digestive tract. An enzyme positions a water molecule at a specific bond in a large nutrient molecule, and the bond splits, one fragment taking hydrogen, the other taking the hydroxyl group. Repeat that thousands of times along a starch chain and you're left with a pile of individual glucose units. A polymer is a large molecule built from repeating subunits called monomers. Starch and glycogen are polymers of glucose. Proteins are polymers of amino acids. And nucleic acids are polymers of nucleotides. Brush border enzymes like maltase, sucrase, lactase, and the peptidases aren't floating loose in the gut. They're embedded directly in the microvilli membrane, so the final hydrolysis happens right where the resulting monomer gets absorbed. Dehydration synthesis builds polymers by removing water, while hydrolysis reverses that by adding water to break the bond. When exam pressure hits, trust the word itself. Hydro means water, lysis means splitting. Question 4. A patient with a fractured mandible is wired shut and placed on a fully liquid diet for 6 weeks. Which digestive process is most directly reduced by the loss of chewing? Your options are A. Chemical digestion in the stomach. B. Mechanical digestion in the mouth. C. Absorption in the duodenum. D. Propulsion through the esophagus. What's your answer? Commit to one before I continue. The correct answer is B. Mechanical digestion in the mouth. B is correct because mastication is the mouth's contribution to mechanical digestion. It physically fragments food without altering its chemical composition, increasing the surface area available to enzymes. Wiring the jaw eliminates this step directly. A is wrong because chemical digestion in the stomach depends on hydrochloric acid and pepsin, which are secreted regardless of whether food was chewed. The liquid diet still triggers gastric secretion. C is wrong because jejunal absorption depends on villi, microvilli, and transport proteins in the small intestine. Chewing does not occur there and does not determine absorptive capacity. D is wrong because propulsion through the esophagus is accomplished by peristalsis, which handles a liquid bolus as readily as a chewed one. Swallowing is not impaired by the absence of chewing. Mechanical digestion rarely gets the credit enzymes do, but it does enormous work. Pancreatic lipase can only act where water meets fat. So breaking one large fat globule into thousands of tiny droplets multiplies the accessible surface area without breaking a single chemical bond. That same surface area principle drives every mechanical process along the tract: chewing in the mouth, churning in the stomach, segmentation in the small intestine, and emulsification by bile salts. Each one physically breaks food apart without changing a single molecule's identity. The stomach's muscularis wall is uniquely thick because it hides a third, oblique layer beneath the usual circular and longitudinal ones. That extra layer lets the stomach twist as well as squeeze, pummeling swallowed food into the creamy suspension called chyme. The cleanest test is simple. Are the molecules coming out chemically different from the ones going in? Chewing bread just makes smaller bread, but salivary amylase turns it into maltose, a genuinely new compound. Size versus identity is the whole distinction. Bile is a frequent trap. It's a liquid secreted by the liver that acts on fat, so it feels chemical, but bile contains no enzymes at all. Its emulsifying action is purely mechanical, and lipase does the actual chemical work afterward. Question 5. A student argues that a swallowed radiopack capsule, which passes intact through the digestive tract and appears whole in the stool, was never actually inside the body. Which anatomical principle supports that argument? Your options are: A. The lumen of the alimentary canal is continuous with the outside world, so a substance enters the body only when it crosses the epithelial lining. B. The peritoneal cavity separates the digestive tract from the body proper, so nothing within the abdomen counts as internal. C. Substances are considered absorbed only after they have been processed by hepatocytes in the liver. D. The mucosa is impermeable to every substance until digestive enzymes have acted on it. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. The lumen of the alimentary canal is continuous with the outside world. So a substance enters the body only when it crosses the epithelial lining. A is correct because the alimentary canal is a tube open at both ends, so its lumen is topologically continuous with the external environment. Material becomes part of the internal environment only at the moment it crosses the epithelium into blood or lymph. The intact capsule never crossed that boundary. B is wrong because the peritoneal cavity is a serous space around the organs and has nothing to do with whether luminal contents are internal. Abdominal organs themselves are unquestionably inside the body. C is wrong because absorption is defined at the epithelial barrier, not at the liver. Fats bypass the liver entirely on first pass and are still absorbed. D is wrong because the mucosa is selectively permeable and absorbs water, ions, and some drugs without enzymatic action. Impermeability is not the reason the capsule stayed outside. The digestive tract is a tube open at both ends, so its inner channel is technically outside the body. Nothing you swallow has truly entered you until it crosses the lining into blood or lymph. Think of the digestive tract less like a container and more like a hallway running through the body, open to the outside world at both entrances. Absorption is the moment something actually steps through a doorway into the house. This is why the mucosa behaves like a fortified frontier rather than a simple lining. Tight junctions between epithelial cells block material from slipping through. Lymphoid tissue in the lamina propria intercepts invaders, and the whole surface turns over every few days, discarding damage instead of repairing it. This is why the distinction between the lumen and the peritoneal cavity matters so much. The lumen is external and normally teeming with microbes, while the peritoneal cavity is truly internal and sterile. So when a perforated ulcer lets luminal content spill into it, the result is peritonitis, a genuine emergency. A swallowed capsule can travel the entire tract and exit in the stool without ever touching your blood, while a dissolved drug absorbed in the duodenum reaches the liver within minutes. That single difference in location is what these questions are really testing. Question 6. A pathologist reports that a gastric tumor has invaded through the mucosa and the submucosa and is now at the border of the smooth muscle responsible for churning and peristalsis. Which layer is the tumor about to enter? Your options are E. Serosa, B. Lamina propria, C. Muscularis externa, D. Adventitia. Which would you go with? Lock it in before the reveal. The correct answer is C. Muscularis externa. C is correct because the four tunics run from the lumen outward as mucosa, submucosa, muscularis externa, and serosa or adventitia. The muscularis externa is the layer immediately outside the submucosa and is the one whose circular and longitudinal smooth muscle generates peristalsis and segmentation. A is wrong because the serosa is the outermost layer of an intraperitoneal organ and lies beyond the muscularis externa. A tumor would have to cross the muscle first to reach it. B is wrong because the lamina propria is a sublayer of the mucosa, deep to the epithelium but still inside the innermost tunic. The tumor has already passed through it. D is wrong because an adventitia replaces the serosa, where an organ is anchored to the body wall rather than suspended, and the stomach has a serosa. Either way, it lies outside the muscle layer. The wall of the alimentary canal is built from four concentric tunics, holding the same order everywhere from esophagus to anal canal. Local variations are just modifications of this template, never departures from it. The mucosa faces the food and secretes, absorbs and defends. The submucosa carries vessels that haul nutrients away and gives the tube elasticity. The muscularis externa generates every motility pattern, and the outermost layer either reduces friction or anchors the tube to the body wall. The mucosa is itself three-layered. Its epithelium lines the lumen directly. The lamina propria beneath carries capillaries and lymphoid tissue, and the deepest muscularis mucosae is a thin muscle sheet that ripples the lining. The submucosal plexus sits near the glands and blood supply, governing secretion and local blood flow. The myenteric plexus sits between the two muscle layers, governing motility. In both cases, position predicts function. The clinical payoff of knowing the layer order is staging. An erosion confined to the mucosa is superficial. One reaching the submucosa gains access to vessels and can spread, and one breaching the muscularis and serosa perforates the wall entirely. Question 7. A biopsy of the lower esophagus in a patient with years of untreated reflux shows simple columnar epithelium, where a different tissue type should be. Which epithelium normally lines the esophagus, and why is that tissue appropriate there? Your options are A. Simple squamous epithelium because it is thin enough to permit rapid absorption. B. Stratified squamous epithelium because its many cell layers resist abrasion from passing food. C. Pseudostratified columnar epithelium because its cilia help move the bolus downward. D. Transitional epithelium because it stretches as the bolus passes. Don't overthink it. Which one feels right? The correct answer is B. Stratified squamous epithelium because its many cell layers resist abrasion from passing food. B is correct because the esophagus is a conduit that is scraped by every swallowed bolus, so it is lined with tough stratified squamous epithelium, the same protective tissue found in the mouth, pharynx and anal canal. Replacement of that tissue by columnar epithelium is the precancerous change called Barrett's esophagus. A is wrong because simple squamous epithelium is a single flattened cell layer suited to diffusion in alveoli and capillaries. It would be shredded by a passing bolus. C is wrong because pseudostratified columnar epithelium with cilia lines the respiratory airways where it moves mucus. The esophagus moves food by muscular peristalsis, not by cilia. D is wrong because transitional epithelium is the stretchable lining of the urinary bladder and ureters. It is not found anywhere in the alimentary canal. Why does chronic reflux transform the esophagus into tissue that looks like intestine? To understand why that's alarming, we need to know what the digestive tract is built to do at each of its stops. The tract uses two epithelial strategies: stratified squamous epithelium with many cell layers, resists abrasion in the mouth, pharynx, esophagus, and anal canal. Simple columnar epithelium, a single thin layer, handles secretion and absorption in the stomach and intestines. No tissue can do both jobs well, so the tract switches types wherever its priorities changed. At the gastroesophageal junction, tough stratified squamous tissue meets fragile, simple columnar tissue in an abrupt line visible on endoscopy. The stomach's single-layer lining survives its own acid only because of a heavy mucus and rapid turnover defense system. The esophagus has none of that because acid was never supposed to reach it. Faced with acid it was never built to handle, the esophageal lining metaplastically converts to a more acid-tolerant columnar tissue. That's adaptive at first, and symptoms may even ease, but this metaplastic tissue carries an elevated risk of progressing to dysplasia and then adenocarcinoma, which is why these patients get surveillance, not just heartburn treatment. Toughness and chemical protection are not the same thing. The esophagus is structurally tough but chemically undefended, while the stomach is structurally delicate but chemically fortified. The tract protects its two ends from abrasion and reserves its middle for absorption, one pattern that explains all four regions at once. Question 8. A researcher selectively blocks the nerve plexus located within the submucosa of the small intestine while leaving the plexus between the muscle layers intact. Which function is most directly impaired? Your options are A. The strength of peristaltic contractions. B. The frequency of segmentation. C. Relaxation of the lower esophageal sphincter. D. Glandular secretion and local blood flow within the mucosa. Got a guess? Lock it in. The correct answer is D. Glandular secretion and local blood flow within the mucosa. D is correct because the submucosal plexus, also called Meissner's plexus, sits in the submucosa and governs secretion by the mucosal glands, the local blood supply, and the small movements of the muscularis mucosae. Blocking it silences secretory and vascular control while motility continues. A is wrong because peristaltic strength is controlled by the mesenteric plexus, which lies between the circular and longitudinal muscle layers. That plexus was deliberately left intact. B is wrong because segmentation frequency is also a motility function driven by the mesenteric plexus, not the submucosal one. Mixing would continue. C is wrong because the lower esophageal sphincter is far upstream in the esophagus and is not controlled by the submucosal plexus of the small intestine. The digestive tract has roughly 100 million neurons of its own, forming a network called the enteric nervous system. It can run digestion entirely on its own, even in a segment of intestine fully cut off from the brain. Routing every secretion and contraction decision through the brainstem would demand enormous nerve traffic. Since the gut is meters long and conditions vary segment to segment on a timescale of seconds, delegating control to the wall itself is simply the more economical solution. The system is built as two plexuses and their location tells you their job. The submucosal, or Meissner's, plexus sits near the glands and capillaries and governs secretion and local blood flow. The mesenteric, or Auerbach's plexus, sits between the muscle layers and governs motility. Both plexuses contain everything needed for independent reflex arcs. Sensory neurons monitor stretch, chemistry, and pH. Interneurons process that information, and motor neurons drive muscle and secretion. When this loop stays entirely within the gut wall, it's called a short reflex. Long reflexes layer on top, with parasympathetic input turning digestion up and sympathetic input turning it down, adjusting the baseline rather than dictating each moment. Blocking one plexus experimentally knocks out its function while leaving the other intact, proving these are genuinely separate control systems, not one diffuse mesh. Question 9. During a thoracic operation, a surgeon notes that the esophagus is bound to the surrounding structures by fibrous connective tissue, rather than being covered by a slick serous membrane. What is this outermost layer and why is it found here? Your options are A. Adventitia, because the thoracic esophagus is anchored to adjacent structures rather than suspended in a serous cavity. B. Serosa, because every organ of the alimentary canal is covered by visceral peritoneum. C. Adventitia, because the esophagus lacks a muscularis externa in the thoracic portion. D. Mesentery, because this tissue carries the vessels and nerves that supply the esophagus. Which one is it? Pause the video if you need more time. The correct answer is A. Adventitia, because the thoracic esophagus is anchored to adjacent structures rather than suspended in a serous cavity. A is correct because where a digestive organ is tethered to the body wall or to neighboring structures instead of hanging free in a serous cavity, the outermost tunic is a fibrous adventitia that anchors it. The thoracic esophagus fits that description, and only its short abdominal segment has a true serosa. B is wrong because a serosa is present only where an organ is covered by visceral peritoneum, which requires the organ to sit within the peritoneal cavity. The thoracic esophagus is above the diaphragm. C is wrong because the esophagus has a well-developed muscularis externa throughout its length, including the thorax. The outer layer type has nothing to do with the presence of muscle. D is wrong because a mesentery is a double sheet of peritoneum suspending an organ within the abdominal cavity. It is not the outermost tunic of the organ wall. The outermost layer of an organ is not always a serosa. Whether it becomes a serosa or an adventitia depends on one thing. Does the organ hang free within a serous cavity, or is it bound to surrounding structures? A serosa is a serous membrane, thin connective tissue covered by mesothelium, secreting fluid so organs can slide against each other. An adventitia is fibrous connective tissue that merges with neighboring structures to hold an organ firmly in place, with no fluid involved at all. The thoracic esophagus runs through the mediastinum, a crowded space with no serous cavity, so its outer layer is adventitia. Once it pierces the diaphragm and enters the abdomen, that final segment gains a true serosa. The ascending colon shows this beautifully. Peritoneum covers its anterior surface where it faces the cavity, while adventitia binds its posterior surface to the body wall. That fixed posterior attachment is exactly why retroperitoneal surgery, like on the pancreas or duodenum, is so technically demanding. Serosa and adventitia are not regional variants of the same structure. They're functional opposites solving opposite problems. Once you see it that way, predicting which covering appears where becomes almost automatic. Question 10. A histology slide of the small intestine is labeled with the 3 sublayers of the innermost tunic. Which sequence correctly names them, moving from the lumen outward? Your options are A. Epithelium submucosa muscularis mucosae. B. Lamina propria epithelium muscularis externa. C. Epithelium lamina propria muscularis mucosae. D. Mesothelium areolar connective tissue inner circular muscle. Take a second. Which answer would you pick? The correct answer is C. Epithelium lamina propria muscularis mucosa. C is correct because the mucosa has exactly 3 parts. The epithelium faces the lumen and does the secreting and absorbing. The lamina propria beneath it is loose areolar tissue carrying capillaries and lymphoid tissue. And the muscularis mucosa is a thin, smooth muscle sheet that produces small local movements of the lining. Is wrong because the submucosa is a separate tunic outside the mucosa entirely, not one of its sublayers. Listing it here confuses 2 levels of organization. B is wrong because the order is inverted and the muscularis externa is a separate tunic rather than a sublayer of the mucosa. The epithelium is always the innermost element. D is wrong because mesothelium is the squamous covering of the serosa on the outer surface of the organ, and the inner circular layer belongs to the muscularis externa. Neither is part of the mucosa. The mucosa isn't one tissue. It's a layered system of its own, with 3 distinct sublayers arranged from the lumen outward. First, the epithelium, a single layer of simple columnar cells, since every absorbed molecule must cross it. Second, the lamina propria, loose connective tissue holding capillaries, lacteals, and lymphoid tissue. Third, the muscularis mucosae, a thin muscle sheet that ripples the lining to keep fresh calm against the absorptive cells. Picture the villi lining the lumen. The epithelium forms the absorptive surface. The lamina propria beneath it carries capillaries and lacteals for nutrient pickup while housing immune tissue. And the muscularis mucosa at the base gently moves the whole lining. The exam trap Muscularis mucosa is thin and only moves the lining, while muscularis externa is thick and moves the entire tube's contents. The submucosa, despite its name, is a completely separate tunic outside the mucosa. This same pattern, epithelium, connective tissue, and optional muscle, repeats across every mucous membrane in the body, which is why understanding this one layer unlocks so many others. Question 11. A patient presents with deep, boring pain that radiates straight through to the mid-back, and imaging shows inflammation of an organ lying behind the peritoneum against the posterior body wall. Which digestive organ best fits this description? Your options are A. Stomach, B. Transverse colon, C. Ileum, D. Pancreas. Before I reveal it, which one do you think is right? The correct answer is D. Pancreas. D is correct because the pancreas is retroperitoneal, lying against the posterior abdominal wall with peritoneum covering only its anterior surface. Because it sits behind the peritoneal sac rather than hanging in it, inflammation produces the deep, poorly localized pain that bores through to the back. A is wrong because the stomach is intraperitoneal, suspended by the greater and lesser omenta. Its position and pain pattern are anterior rather than retroperitoneal. B is wrong because the transverse colon is intraperitoneal and suspended by the transverse mesocolon. Only the ascending and descending portions of the colon are retroperitoneal. C is wrong because the ileum is intraperitoneal and hangs freely on the mesentery proper. It is one of the most mobile parts of the tract, not a fixed posterior organ. Deep boring pain that radiates to the back is not random. It's a direct clue about where an organ sits relative to the peritoneum. Intraperitoneal organs are wrapped in visceral peritoneum and swing freely on a mesentery. Retroperitoneal organs lie flattened against the back wall with no mesentery, covered only on their front face, which is why they're relatively fixed. Picture a cross-section through the back of the abdomen. The jejunum hangs freely on its mesentery, while the pancreas is pinned flat against the posterior wall, covered by peritoneum on only one side. The parietal peritoneum is richly wired with somatic nerves that pinpoint pain exactly, producing the sharp, localized ache of appendicitis. A retroperitoneal organ signals instead through visceral afferents, which are vague and refer pain to the back. Exactly why pancreatitis feels so different. Retroperitoneal describes position behind the peritoneum, while accessory describes a role in digestion, and organs can mix and match both labels independently. Sorting position and function separately is what keeps this distinction exam-proof. Question 12. A surgeon explains to a family why the small intestine does not tangle on itself, despite being several meters long and freely mobile within the abdomen. Which structure provides that support while also carrying the vessels and nerves that supply the intestine? Your options are A. Greater omentum, B. Mesentery proper, C. Parietal peritoneum, D. Teniae Coli. What's your answer? Commit to one before I continue. The correct answer is B. Mesentery proper. B is correct because the mesentery proper is a fan-shaped double sheet of peritoneum that suspends the jejunum and ileum from the posterior abdominal wall. It holds the loops in a predictable arrangement and serves as the conduit for the arteries, veins, lymphatics, and nerves reaching the bowel. A is wrong because the greater omentum is the fatty apron draping from the greater curvature of the stomach over the anterior abdominal organs. It insulates and walls off infection, but does not suspend the small intestine. C is wrong because the parietal peritoneum lines the abdominal wall itself. It forms the outer boundary of the cavity rather than suspending organs within it. D is wrong because the Teniae coli are 3 longitudinal muscle bands in the wall of the large intestine. They gather the colon into Haustra and have no role in suspending the small bowel. 6 meters of small intestine must fit into a crowded abdomen without twisting, migrating, or losing its blood supply. One structure solves all of these problems at once. A mesentery is 2 sheets of peritoneum fused back to back, forming a flat sail-like membrane between the posterior body wall and an organ. Its protected interior is where blood vessels, lymphatics, and nerves travel, so support and supply happen through the same design. The mesentery proper attaches along a short oblique line on the posterior wall, yet fans out to gather many meters of jejunum and ileum into orderly loops. The superior mesenteric artery branches through it toward the bowel, while veins and lymphatics run alongside back toward the liver. Each named fold has its own job. The greater omentum drapes like a fatty apron over the abdominal organs. The lesser omentum connects the liver to the stomach's lesser curvature. The mesocolon suspends the colon, and the mesentery proper suspends the jejunum and ileum. The greater omentum can even migrate to wall off infection, and mesenteric fat signals directly to the liver, showing this anatomy has real physiological reach. Remember, every mesentery is peritoneum, but most peritoneum is not a mesentery. Question 13. After a meal, a pharmacologist notes that a drug absorbed from the jejunum reaches the liver at high concentration and is extensively metabolized there before any of it reaches the systemic circulation. Which vascular arrangement explains this finding? Your options are: A. Venous blood draining the intestines is collected by the hepatic portal vein and delivered to the liver before returning to the heart. B. The hepatic artery carries intestinal venous blood directly into the hepatic sinusoids. C. Absorbed drugs enter the lacteals and are carried to the liver through the thoracic duct. D. The celiac trunk gathers venous blood from the intestines and routes it through the liver. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Venous blood draining the intestines is collected by the hepatic portal vein and delivered to the liver before returning to the heart. A is correct because the hepatic portal system is the defining feature of splanchnic venous drainage. Nutrient-rich and drug-rich blood from the stomach, intestines, pancreas, and spleen enters the hepatic portal vein, percolates through the liver sinusoids past the hepatocytes, and only then continues through the hepatic veins to the vena cava. B is wrong because the hepatic artery delivers oxygenated arterial blood from the aorta to the liver. It does not collect venous blood from the gut. C is wrong because lacteals carry the products of fat digestion as chylomicrons, and the thoracic duct empties into the venous system at the base of the neck, bypassing the liver entirely on first pass. D is wrong because the celiac trunk is an artery branching from the abdominal aorta to supply the stomach, liver, spleen, and pancreas. Arteries deliver blood to organs rather than draining them. Blood leaving the stomach, intestines, pancreas, and spleen doesn't head straight for the heart. Instead, it's funneled into the hepatic portal vein and delivered first to the liver, guaranteeing the liver first access to everything absorbed from a meal. 3 unpaired branches of the abdominal aorta feed the system. The celiac trunk supplies the stomach, liver, spleen, and pancreas. The superior mesenteric artery supplies most of the small intestine and proximal colon, and the inferior mesenteric artery supplies the distal colon. Together they claim roughly a quarter of resting cardiac output. Inside the liver, blood enters at the corners of each hexagonal lobule through portal triads, then flows inward past hepatocytes and Kupffer cells, the resident macrophages that engulf bacteria and debris. Cleaned blood collects in the central vein before heading toward the vena cava. A swallowed drug must pass through the liver before reaching its target, and enzymes there can destroy much of it, which is why some medications are given by injection, patch, or under the tongue instead. Fat is the deliberate exception. Chylomicrons are too big for capillaries, so they travel through lymph and reach circulation without liver screening. When the system fails, as in cirrhosis, pressure backs up into collateral veins, causing esophageal varices and letting unfiltered toxins reach the brain. The hepatic portal system isn't a plumbing quirk. It's the structural proof that the liver inspects almost everything absorbed from the gut. Question 14. A perforated gastric ulcer erodes completely through the stomach wall and allows acidic gastric contents and bacteria to escape into the space between the visceral and parietal peritoneum. Which complication is the immediate concern? Your options are A. Hepatitis from portal spread of bacteria. B. Barrett's esophagus from prolonged acid exposure. C. Diverticulitis from trapped fecal debris. D. Peritonitis from contamination of the serous cavity. Which would you go with? Lock it in before the reveal. The correct answer is D. Peritonitis from contamination of the serous cavity. D is correct because the peritoneal cavity is a slit-like serous space that normally holds only a thin film of lubricating fluid and is sterile. Spilling acid and gut bacteria into it produces peritonitis, a rapidly spreading inflammation of the membrane that is a surgical emergency. R is wrong because hepatitis is inflammation of liver tissue, most often viral or toxic in origin. A perforation delivers contents into the peritoneal cavity, not into hepatocytes. B is wrong because Barrett's esophagus is a slow metaplastic change in the esophageal lining caused by chronic reflux over years. It is not an acute consequence of perforation. C is wrong because diverticulitis is inflammation of outpouchings in the colon wall and arises from trapped material inside those pouches. It has no connection to a gastric perforation. The peritoneum is the body's largest serous membrane, built from two continuous sheets with a thin space between them. The parietal layer lines the abdominal wall. The visceral layer covers the digestive organs, and between them lies the peritoneal cavity. Calling this a cavity overstates it. Normally it's just a slit holding a thin film of lubricating fluid, letting constantly moving digestive organs slide against each other and the body wall without generating friction or damage. The peritoneum is sterile, enormous in surface area, richly vascularized, and drained by extensive lymphatics. Those same features make it an efficient absorptive surface for peritoneal dialysis, but also a dangerously efficient route for infection to spread. The lumen of the gut is continuous with the outside world, normally full of bacteria and lined by mucosa. The peritoneal cavity is genuinely internal, normally sterile and lined by mesothelium, so when a perforation lets lumen contents cross that boundary, peritonitis follows fast. Nothing about the bacteria changes when an ulcer perforates. What changes is which side of the epithelial barrier they occupy, and that single fact explains the entire clinical picture of peritonitis. Question 15. A patient reports that digestive symptoms flare during periods of intense work stress, with noticeably slowed gastric emptying, reduced secretion, and tightened sphincters. Which autonomic influence accounts for this pattern? Your options are A. Parasympathetic stimulation carried by the vagus nerve. B. Enteric short reflexes operating independently of the brain. C. Sympathetic outflow carried by the thoracic and lumbar splanchnic nerves. D. Pelvic splanchnic stimulation of the distal colon. Don't overthink it. Which one feels right? The correct answer is C. Sympathetic outflow carried by the thoracic and lumbar splanchnic nerves. C is correct because the sympathetic division is the fight or flight arm of autonomic control, and its net effect on digestion is inhibitory. It slows motility, reduces glandular secretion, contracts sphincters, and shunts blood away from the splanchnic circulation towards skeletal muscle. A is wrong because the vagus nerve carries parasympathetic fibers that stimulate digestion, increasing motility and secretion and relaxing sphincters. Its effect is the opposite of what is described. B is wrong because enteric short reflexes are local circuits within the gut wall that respond to stretch and luminal chemistry. They do not produce a global stress-linked shutdown of digestive activity. D is wrong because pelvic splanchnic nerves are parasympathetic and stimulate the distal colon and rectum. They would promote motility rather than suppress it. Instead of memorizing which system does what, reason from purpose. Sympathetic activation prepares the body to fight or flee, and digestion is irrelevant to survival in that moment. Parasympathetic activation dominates when the body is safe and at rest, exactly when processing a meal makes sense. Every specific effect follows from that priority. Sympathetic outflow slows motility, reduces secretion, contracts sphincters, and diverts blood to skeletal muscle. Parasympathetic outflow does the opposite. It increases motility, promotes secretion, and relaxes sphincters so material can move forward. Anatomically, parasympathetic supply travels mainly through the vagus nerve, covering everything from the esophagus down to roughly the transverse colon, with pelvic splanchnic nerves taking over for the descending colon, sigmoid colon, and rectum. Sympathetic supply travels through thoracic and lumbar splanchnic nerves by way of prevertebral ganglia. Autonomic input does not replace enteric control. The enteric nervous system in the gut wall generates the actual reflexes, sensing stretch and chemistry and driving muscle and glands directly. Autonomic fibers just modulate that local circuitry, setting the gain rather than issuing commands. So a stressed gut hasn't lost its reflexes. They're simply operating against a suppressed background. The counterintuitive detail is sphincter direction. Stimulating digestion means relaxing sphincters so material can advance, while inhibiting digestion means contracting them to hold material in place. The vagus nerve drives much of this directly, priming gastric secretion, promoting emptying, and stimulating the pancreas, which is why vagotomy sharply reduces acid output and delays emptying. Question 16. A patient recovering from a stroke coughs while drinking and has liquid come back out through the nose. Which structure most likely failed to perform its role in the pharyngeal phase of swallowing? Your options are A. The soft palate, which normally rises to seal off the nasopharynx. B. The epiglottis, which normally folds over the laryngeal opening. C. The hard palate, which normally supports the tongue as it mashes food. D. The upper esophageal sphincter, which normally relaxes to admit the bolus. Got a guess? Lock it in. The correct answer is A. The soft palate, which normally rises to seal off the nasopharynx. A is correct because during the pharyngeal phase, the soft palate and uvula elevate reflexively and press against the posterior pharyngeal wall, sealing the nasopharynx so the bolus cannot be forced upward into the nasal cavity. Nasal regurgitation is the classic sign that this seal failed. B is wrong because the epiglottis protects the airway by folding over the glottis, so its failure sends material into the trachea and lungs rather than into the nose. C is wrong because the hard palate is a rigid bony surface used during chewing and the voluntary buccal phase. It cannot fail dynamically because it does not move. D is wrong because failure of the upper esophageal sphincter to relax would obstruct the bolus at the entrance to the esophagus, causing a sensation of food sticking rather than nasal regurgitation. For 1 second, the pharynx completely reverses its job, turning from an open-air passage into a sealed food conduit. Every event happens simultaneously, not step by step, which is why this phase is reflexive rather than voluntary. 2 seals close at once. The soft palate presses against the throat wall to shut off the nose, while the larynx rises and the epiglottis folds down to shut off the windpipe. Breathing briefly stops and the upper esophageal sphincter opens to let food through. The hard palate is bone-supported and rigid, giving the tongue a firm surface to press food against. The soft palate is muscular and mobile, letting it act as a valve. And mixing up these two roles makes the whole mechanism impossible to understand. When the soft palate seal fails, liquid escapes up through the nose. When the epiglottis fails, material drops into the trachea, causing aspiration. This reflex is timed by a swallowing center in the brain stem, so strokes there disrupted even when the muscles work fine. And aspirated bacteria can cause deadly pneumonia. Think of swallowing not as pushing food along, but as a 1-second airway shutdown that happens to move food. That framing predicts both the timing and exactly what goes wrong when a seal fails. Question 17. A student is asked which nutrient class is the first to undergo chemical digestion and where that digestion begins. Which answer is correct? Your options are A. Protein, beginning in the stomach with pepsin. B. Carbohydrate, beginning in the mouth with salivary amylase. C. Fat, beginning in the duodenum with pancreatic lipase. D. Nucleic acid, beginning in the mouth with a lingual nuclease. Which one is it? Pause the video if you need more time. The correct answer is B. Carbohydrate, beginning in the mouth with salivary amylase. B is correct because salivary amylase from the salivary glands begins splitting starch into maltose and short glucose chains while the food is still being chewed. Because the mouth is the first station in the tract, carbohydrate is the first nutrient class chemically attacked. A is wrong because protein digestion is genuinely the first to occur in the stomach, but the stomach is downstream of the mouth. Salivary amylase has already acted by then. C is wrong because pancreatic lipase does the bulk of fat digestion, but it acts in the duodenum, which is well past both the mouth and the stomach. D is wrong because there is no lingual nuclease. Nucleic acid digestion begins in the small intestine with pancreatic ribonucleus and deoxyribonucleus. Chemical digestion doesn't wait for the stomach. Salivary amylase starts breaking down starch into maltose within seconds of the first bite, making carbohydrate the first nutrient class attacked anywhere in the digestive tract. Saliva carries salivary amylase for starch, mucin to bind the chewed bolus together, lysozyme and immunoglobulin A for defense against bacteria, and bicarbonate to buffer oral acids and protect enamel. It also dissolves food, since taste receptors only respond to molecules in solution. The order matters. Carbohydrate digestion starts in the mouth with salivary amylase. Protein starts in the stomach once acid activates pepsin. And fat doesn't begin in earnest until bile salts and pancreatic lipase reach it in the small intestine. Salivary amylase works only briefly, functioning at the mouth's near neutral pH before stomach acid destroys it. So it demonstrates a principle of timing rather than doing the bulk of the work. Every nutrient class finishes digestion in the small intestine, no matter where it started. And don't confuse order with volume. Pancreatic amylase and lipase do far more work than their salivary and lingual counterparts, but they are never first. Question 18. A child has painful swelling anterior to and just below both ears, and the clinician suspects mumps. Which salivary gland is affected, and where does its duct empty? Your options are A. Submandibular gland with the duct opening under the tongue. B. Sublingual gland with the duct opening in the floor of the mouth. C. Submandibular gland with the duct opening near the upper second molars. D. Parotid gland with the duct opening near the upper second molars. Take a second. Which answer would you pick? The correct answer is D. Parotid gland with the duct opening near the upper second molars. D is correct because the parotid glands are the largest salivary glands and sit anterior to the ears between the skin of the cheek and the masseter muscle, which is exactly where mumps produces its characteristic swelling. Each parotid duct crosses the cheek and opens into the vestibule near the upper second molar. A is wrong because the submandibular glands lie along the medial surface of the mandible, well below and behind the described swelling, and their ducts open under the tongue. B is wrong because the sublingual glands are the smallest pair and sit in the floor of the mouth beneath the tongue. Their position does not match swelling in front of the ear. C is wrong because this pairs the right duct location with the wrong gland. The submandibular ducts open under the tongue, not near the upper molars. Swelling in front of the ear points to one gland every time, the parotid. Let's map out all three major salivary glands because their locations, ducts, and secretions are frequently confused with one another. The parotid gland is largest, sitting anterior to the ear, but its duct travels all the way across the cheek to open near the upper second molars. The submandibular gland sits along the jaw and opens under the tongue, producing most resting saliva. The sublingual gland is smallest, sitting in the floor of the mouth and opening there too. Saliva isn't uniform. Parotid secretion is thin and enzyme rich. Sublingual secretion is thick and mucus. And the submandibular gland produces a blend of both, which is why the character of saliva shifts depending on which glands are dominant. Parasympathetic input drives copious watery saliva during eating, while sympathetic input produces the thick, sparse saliva behind a dry mouth before stressful moments. Remarkably, salivation is also a conditioned reflex, triggered not just by food in the mouth but by its sight, smell, or even the thought of it, priming the stomach the same way. The trickiest pairing is gland location versus duct opening. The parotid gland sits by the ear, but its duct opens far away near the upper molars, while the submandibular gland sits low and opens under the tongue. Memorize these as linked pairs, not as facts you derive from one another. Question 19. A dental hygienist describes a class of teeth that are cone-shaped, sharply pointed, and positioned immediately lateral to the front cutting teeth. Which class is being described and what mechanical task does it perform? Your options are A. Incisors, adapted for cutting and biting off pieces of food. B. Premolars, adapted for crushing food between broad cusps. C. Canines, adapted for tearing and piercing food. D. Molars, adapted for the heaviest grinding. Before I reveal it, which one do you think is right? The correct answer is C. Canines, adapted for tearing and piercing food. C is correct because the canines, also called cuspids, are the pointed teeth just lateral to the incisors and are the sharpest teeth in the mouth. Their single conical cusp concentrates force on a small area, which suits them to tearing and piercing tough food. A is wrong because incisors are the flat chisel-shaped teeth at the very front of the arch. They shear rather than pierce, and they sit medial to the canines. B is wrong because premolars, or bicuspids, sit behind the canines and have broad crowns with rounded cusps for crushing. They are not sharply conical. D is wrong because molars are the large flat-crowned teeth at the back of the mouth and perform the heaviest grinding. They are the farthest structures from the front-cutting teeth. Teeth are a case study in form-following function, and their internal structure tells a story about why dental disease works the way it does. Incisors are flat and chisel-edged for shearing, Canines are conical for piercing and tearing. Premolars have rounded cusps for crushing, and molars have the widest crowns for grinding. Front to back, this mirrors exactly what a mouthful of food goes through. A tooth is layered by hardness. Enamel covers the crown and is the hardest substance in the human body. Dentin beneath it forms the bulk of the tooth, and the pulp cavity at the center holds the blood vessels and nerves. Enamel's defining property is that it cannot regenerate. Oral bacteria turn sugars into acid that dissolves enamel, and unlike bone, there is no repair process, which is why prevention, fluoride, and saliva's buffering matter so heavily. Chewing itself relies on the masseter, which generates the greatest force, the temporalis, which elevates and retracts the jaw, and the pterygoids, which produce the side-to-side grinding motion that lets molars mill food. Question 20. A patient waiting to give a presentation reports a dry, sticky mouth despite having normal salivary gland anatomy and normal fluid intake. Which explanation fits best? Your options are: A. Sympathetic activation is producing a scanty, thick, mucus-rich saliva. B. The salivary nuclei in the pons and medulla have been damaged. C. Parasympathetic stimulation is producing copious, watery saliva. D. Lysozyme secretion has been suppressed by circulating stress hormones. What's your answer? Commit to one before I continue. The correct answer is A. Sympathetic activation is producing a scanty, thick, mucus-rich saliva. A is correct because salivation is under autonomic control and the two divisions produce different saliva. Sympathetic activity during stress yields a small volume of thick, mucus-heavy secretion, which is why the mouth feels dry and tacky before public speaking, even though the glands are working. B is wrong because damage to the brainstem salivary nuclei would cause a persistent deficit rather than a dry mouth that appears only during anxiety and resolves afterward. C is wrong because parasympathetic stimulation produces abundant, thin, enzyme-rich saliva. That is the opposite of the reported sensation. D is wrong because lysozyme is an antibacterial enzyme in saliva and contributes almost nothing to saliva volume or consistency. Its loss would not create a dry mouth. Dry mouth before a presentation doesn't mean your salivary gland shut down. They're still working, just under different instructions, producing a different kind of fluid entirely. Control starts in salivary nuclei in the pons and medulla. Parasympathetic fibers drive abundant watery saliva packed with amylase for digestion, while sympathetic fibers cut volume and shift the fluid toward thick mucus, appropriate when the body has more urgent priorities. Direct stimulation comes from receptors in the mouth responding to food, actually present, and to chewing. Anticipatory stimulation comes from the sight, smell, or thought of food. A genuine conditioned reflex just like Pavlov's dogs, and it shares circuitry with the cephalic phase of gastric secretion. Picture the pathway itself. Nerve signals from the brain stem branch into the same glands, one root producing thin watery flow, the other producing thick scant mucus. Severe salivary loss from autoimmune disease, radiation, or anticholinergic drugs reveals just how much saliva does. Losing it brings dental decay, swallowing difficulty, dull taste, and oral infections. Proof that this fluid lubricates, buffers, digests, and defends all at once. Question 21. An instructor asks a student to identify the only phase of swallowing that is under conscious control and to describe what happens during it. Which response is correct? Your options are: A. The pharyngeal phase, during which the epiglottis folds down and closes the airway. B. The buccal phase, during which the tongue presses the bolus against the palate and drives it into the oropharynx. C. The esophageal phase, during which peristaltic waves carry the bolus toward the stomach. D. The gastric phase, during which the lower esophageal sphincter relaxes to admit the bolus. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. The buccal phase, during which the tongue presses the bolus against the palate and drives it into the oropharynx. B is correct because deglutition has 3 phases and only the first is voluntary. In the buccal phase, the tongue compresses the bolus against the hard palate and pushes it posteriorly into the oropharynx. The moment the bolus contacts the pharyngeal receptors, control passes to an involuntary brainstem reflex. A is wrong because the pharyngeal phase is reflexive and is coordinated by the swallowing center in the medulla and pons. Epiglottic closure cannot be consciously timed. C is wrong because the esophageal phase is driven by peristalsis of the esophageal muscularis and is entirely involuntary, which is why a swallow cannot be aborted once the bolus is well down the tube. D is wrong because there is no gastric phase of swallowing. The gastric phase is a stage of gastric secretion, not of deglutition. Swallowing is the clearest example in the body of an act that starts under your control and finishes without it. The handoff happens at one exact location, not gradually, and that's exactly what the 3 phases of deglutition are built to capture. The buccal phase is voluntary work done by the tongue, compressing and shaping the bolus before pushing it back. The pharyngeal phase begins the instant the bolus touches the oropharyngeal receptors, and control passes irreversibly to the brainstem. The esophageal phase then carries the bolus down by peristalsis, and it's involuntary too. A swallowing center in the medulla and pons executes a fixed sequence in about 1 second. The soft palate seals the nasopharynx. The larynx rises. The epiglottis folds over the glottis, breathing pauses, and the upper esophageal sphincter relaxes. None of it can be adjusted once triggered. The esophagus itself shifts from skeletal muscle in the upper third to mixed muscle in the middle to smooth muscle in the lower third. But even the skeletal portion is driven reflexively during the swallow, not by conscious command. So its presence doesn't mean voluntary control exists there. Voluntary control is useful only for deciding when to swallow and positioning food in the mouth. Once the bolus enters the pharynx, the airway is exposed, so the brainstem takes over completely, running the sequence to completion regardless of whether the bolus was ready. Question 22. A patient with impaired swallowing after a brainstem stroke develops recurrent pneumonia affecting the lower lobes of the lungs. Which failure during the pharyngeal phase most directly explains this complication? Your options are A. The soft palate failed to seal off the nasopharynx. B. The upper esophageal sphincter failed to relax on time. C. The epiglottis failed to fold over the laryngeal opening. D. Esophageal peristalsis was too weak to clear the bolus. Which would you go with? Lock it in before the reveal. The correct answer is C. The epiglottis failed to fold over the laryngeal opening. C is correct because during the pharyngeal phase, the larynx elevates and the epiglottis tips down over the glottis, routing the bolus posteriorly into the esophagus and sealing the airway. When that closure is mistimed, material enters the trachea and reaches the lungs, which is aspiration and the direct cause of aspiration pneumonia. A is wrong because failure of the soft palate sends material upward into the nasal cavity, producing nasal regurgitation rather than pulmonary infection. B is wrong because a sphincter that fails to relax obstructs the bolus at the top of the esophagus. Food is held back rather than diverted into the airway. D is wrong because weak esophageal peristalsis leaves food lodged in the esophagus and causes the sensation of food sticking. The airway has already been sealed by that point in the sequence. In the pharynx, the paths for food and air actually cross each other, meeting in the oropharynx. Every single swallow has to manage that crossing correctly, or material can end up in the wrong tube. No other mammal takes this risk. The human larynx sits lower in the neck than in other species, which expands the resonating space and makes speech possible, but it also lengthens the shared pathway and creates a real risk of choking. The epiglottis is a leaf-shaped flap of cartilage at the base of the tongue, but it doesn't close on its own. The suprahyoid muscles lift the larynx upward, while the tongue base pushes the epiglottis downward, and the two movements meet to seal the airway. When the mechanism fails, material enters the trachea, and after a stroke, reduced sensation can mean no cough warns anyone at all. Gravity carries that material to the lower and posterior lung segments. And because the bacteria come from the mouth, oral hygiene becomes real prevention. Don't picture swallowing as transporting food. Picture it as protecting the airway. Seen that way, every elaborate step in the sequence stops looking like over-engineering and starts looking necessary. Question 23. A physiologist explains that a swallow can be started at will but cannot be halted once the bolus is partway down the esophagus. Which structural feature of the esophageal muscularis explains this transition in control? Your options are: A. The entire esophagus contains smooth muscle governed by the enteric nervous system. B. The entire esophagus contains skeletal muscle governed by somatic motor neurons. C. The muscularis is replaced by an adventitia in the lower esophagus. D. The muscularis shifts from skeletal muscle in the upper third to smooth muscle in the lower third. Don't overthink it. Which one feels right? The correct answer is D. The muscularis shifts from skeletal muscle in the upper third to smooth muscle in the lower third. D is correct because the esophagus is unusual in changing its muscle type along its length. The upper third is skeletal muscle, which allows the swallow to be initiated voluntarily. The middle third is mixed, and the lower third is smooth muscle under wholly involuntary control. That gradient is exactly why the act starts under will and finishes without it. A is wrong because if the whole tube was smooth muscle, no part of swallowing could be initiated voluntarily, yet the buccal and early pharyngeal events clearly are. B is wrong because if the whole tube was skeletal muscle, conscious control would extend the full length and a swallow could in principle be stopped at any point. C is wrong because the adventitia is the outermost connective tissue layer of the esophagus and has nothing to do with muscle type or with voluntary control. The esophagus does something no other part of the digestive tract does. It changes muscle type along its length. That gradient explains why you can start a swallow whenever you like, but can never stop one once it begins. Skeletal muscle up top is under voluntary somatic control, so you decide when to swallow. Smooth muscle below answers only to autonomic and enteric neurons. So once the bolus passes the transition point, the rest of the trip runs on reflex alone. Structurally, the esophagus is a simple tube about 25 centimeters long, passing behind the trachea and through the diaphragm's esophageal hiatus. Its lining is stratified squamous epithelium built to withstand abrasion, and its outer layer is adventitia in the thorax, but true serosa only in the small abdominal segment below the diaphragm. The upper esophageal sphincter keeps air out of the gut, so its failure causes food catching in the throat or swallowed air. The lower esophageal sphincter keeps stomach acid from washing back up, so its failure causes heartburn. The diaphragm normally reinforces that lower sphincter, which is why hiatal hernia, where the stomach slides upward, so often brings reflux along with it. Every detail of the esophagus, from its muscle gradient to its sphincters, exists to serve one purpose: safe, one-way transport from mouth to stomach. Question 24. A patient reports burning pain behind the sternum that is worse after large meals and worse still when lying flat at night. Which mechanism best explains these symptoms? Your options are A. The lower esophageal sphincter relaxes inappropriately, allowing acidic gastric contents to wash back into the esophagus. B. The upper esophageal sphincter remains open, allowing swallowed air to distend the stomach. C. The pyloric sphincter fails to close, allowing bile to enter the stomach from the duodenum. D. Esophageal peristalsis reverses direction and actively drives the bolus upward. Got a guess? Lock it in. The correct answer is A. The lower esophageal sphincter relaxes inappropriately, allowing acidic gastric contents to wash back into the esophagus. A is correct because the lower esophageal sphincter normally stays contracted between swallows and is reinforced by the surrounding diaphragmatic muscle. When it is weak or relaxes at the wrong time, acidic gastric contents reflux upward, and because the esophageal lining lacks the stomach's thick alkaline mucus, that acid causes the burning sensation of heartburn. B is wrong because an incompetent upper esophageal sphincter would allow air into the digestive tract, causing belching and bloating rather than a burning pain behind the sternum. C is wrong because duodenal contents refluxing into the stomach can irritate the gastric lining, but that would not produce esophageal symptoms that worsen with position change. D is wrong because esophageal peristalsis does not reverse. Its wave direction is fixed by the sequential activation of the muscularis from top to bottom. Burning behind the sternum after big meals, worse lying flat, points to one structure, the lower esophageal sphincter, and the two triggers reveal exactly how it fails. The lower esophageal sphincter isn't a discrete ring like the pylorus. It's a zone of tonic muscle contraction reinforced by the diaphragm's crural fibers, so reflux can result from either mechanism failing, and a full stomach or a flat position simply exposes that weakness. The damage comes from a mismatch in defenses. The stomach lining has alkaline mucus, tight junctions, and rapid turnover, while the esophagus only has tough squamous epithelium built for abrasion, not acid. So each tissue is defenseless against the insult it doesn't expect. Most reflux comes from transient, inappropriate sphincter relaxations worsened by fatty meals, alcohol, and large portions, not a permanently weak sphincter. Chronic exposure eventually converts esophageal lining into columnar, intestinal-type tissue called Barrett's esophagus, which paradoxically tolerates acid better, even as cancer risk climbs. When long-standing heartburn quietly fades, it may signal tissue transformation rather than healing, which is why surveillance endoscopy, not reassurance, is the right response, and why treatment with acid suppression controls injury without fixing the underlying mechanical failure. Question 25. An astronaut in microgravity eats a full meal and swallows normally. Which mechanism explains why food still reaches the stomach without any assistance from gravity? Your options are A. The esophagus is short enough that a bolus falls through it under its own weight. B. Circular muscle contracts behind the bolus, while the muscle ahead of it relaxes, squeezing it forward. C. Negative pressure within the thoracic cavity draws the bolus down toward the stomach. D. The lower esophageal sphincter actively pulls the bolus into the stomach. Which one is it? Pause the video if you need more time. The correct answer is B. Circular muscle contracts behind the bolus while the muscle ahead of it relaxes, squeezing it forward. B is correct because peristalsis is an active muscular squeeze, not a passive drop. The circular layer contracts behind the bolus to push it while the segment ahead relaxes to open the path, producing a traveling wave strong enough to move food uphill. That is why a person can swallow while lying down or upside down. A is wrong because weight is irrelevant in microgravity, and even on Earth swallowing works against gravity. The mechanism cannot depend on the bolus falling. C is wrong because thoracic pressure changes drive airflow into the lungs during breathing. They do not generate the directional force that moves a bolus through the esophagus. D is wrong because a sphincter is a ring of muscle that opens and closes a passage. It relaxes to admit the bolus but cannot generate pulling force along the tube. You can swallow water while standing on your head and it still reaches your stomach. That single fact rules out gravity and proves peristalsis is an active muscular squeeze that can move material uphill. The wave has a specific architecture. Circular muscle behind the bolus contracts and narrows the tube. Circular muscle ahead relaxes to open a low resistance path. And longitudinal muscle in the receiving segment shortens to draw the tube forward, all coordinated by the mentric plexus. The step most often overlooked is that relaxation ahead of the bolus is what makes the system efficient. Pushing against a closed tube would take enormous force, but pushing into an already open segment takes very little, which is why swallowing takes only seconds. Peristalsis is not the only pattern in the gut. The stomach and small intestine rely on churning and segmentation to mix. The colon adds haustral contractions and mass movements, and in achalasia, the mesenteric neurons degenerate so the wave weakens and the lower sphincter fails to relax, causing food to back up. On exams, words like wave, propel, advance, or travel signal peristalsis, while contractions that mix without moving contents forward describe segmentation instead. The real question is always whether the contents are actually going anywhere. Question 26. An endoscopist notes prominent longitudinal folds lining an empty stomach and observes that these folds progressively flatten as the stomach is inflated with air. What are these folds and what do they accomplish? Your options are A. Plica circulars, permanent folds that slow the passage of contents and improve mixing. B. Haustra, pouches produced by the tone of longitudinal muscle bands. C. Villi, mucosal projections that greatly increase absorptive surface area. D. Ruga, temporary folds that allow the stomach to expand and add secretory surface. Take a second. Which answer would you pick? The correct answer is D. Rugae, temporary folds that allow the stomach to expand and add secretory surface. D is correct because ruga are the large longitudinal folds of the gastric mucosa that appear when the stomach is empty. They flatten out like the pleats of an accordion as the stomach fills, permitting dramatic expansion, and while present they add surface area for the gastric glands to secrete into. A is wrong because plicae circulars belong to the small intestine, run transversely and are permanent. They do not flatten when the organ fills. B is wrong because Haustra are the pouches of the large intestine created by the tone of the Teniae coli. They are not a gastric feature. C is wrong because villi are finger-like projections of the small intestinal mucosa dedicated to absorption. The stomach absorbs almost nothing and has no villi. The stomach works like a holding tank with a grinder attached. As the widest part of the alimentary canal, it collapses to the size of a sausage when empty, but stretches to hold a liter or more of a meal, up to 4 liters at maximum, letting you eat in minutes and digest over hours. 4 regions divide the stomach, each with a distinct job. The cardia surrounds the entrance and receives the bolus. The fundus is the dome that traps swallowed air. The body is where most churning happens, and the pyloric region funnels chyme through the pyloric sphincter into the duodenum. Rugae are the folds lining an empty stomach, running longitudinally and flattening like an accordion as it fills, both easing expansion and adding surface area for gastric glands. Plica circularis in the small intestine look similar but never flatten, because their job is to slow transit and force chyme to spiral, not to accommodate stretching. 2 curvatures shape the stomach. The shorter, lesser curvature anchors the lesser omentum, while the longer, greater curvature anchors the greater omentum draping over the abdominal organs. Between the rugae Millions of gastric pits descend to gastric glands, giving this simple-looking bag the capacity to produce 2 to 3 liters of gastric juice daily. The regional names trip people up because cardia and fundus sound like opposite ends, but both actually sit at the top of the stomach. The cardia is the small entry zone near the esophagus, and the fundus is the dome bulging above it. Fix that one relationship and most regional identification questions fall into place. Question 27. A student asks why the stomach can churn a meal far more forcefully than any other segment of the alimentary canal. Which structural feature best answers the question? Your options are: A. Its mucosa contains a thicker muscularis mucosae than any other organ. B. Its submucosa contains an extra layer of dense irregular connective tissue. C. Its muscularis externa contains a third oblique layer in addition to the circular and longitudinal layers. D. Its serosa is reinforced externally by the greater omentum. Before I reveal it, which one do you think is right? The correct answer is C. Its muscularis externa contains a third oblique layer in addition to the circular and longitudinal layers. C is correct because everywhere else in the tract the muscularis externa has 2 layers, an inner circular and an outer longitudinal. The stomach adds an innermost oblique layer, making its muscularis the thickest in the entire canal and giving it the 3-dimensional pull needed to pummel a bolus into calm. A is wrong because the muscularis mucosa is a thin sheet that produces small movements of the lining itself. It is far too slight to churn a meal. B is wrong because the submucosa is connective tissue carrying vessels and the submucosal plexus. Connective tissue does not contract. D is wrong because the greater omentum drapes over the abdominal organs and stores fat and lymphoid tissue. It provides no contractile force to the stomach wall. 2 muscle layers can only narrow and shorten a tube. Neither of those actions can grind anything, and that single limitation explains why the stomach has a muscle layer found nowhere else in the digestive tract. The standard gut wall has an inner circular layer and an outer longitudinal layer, good for narrowing and shortening. The stomach adds an innermost oblique layer, supplying force along a third axis, making it the thickest muscularis in the tract and enabling true 3-dimensional churning. Contraction waves start weak in the stomach body and intensify near the pylorus, which stays only slightly open. Each strong wave lets a few milliliters of calm escape into the duodenum while the rest jets backward, a process called retropulsion for another round of grinding. The duodenum can only neutralize acid, emulsify fat, and deliver enzymes at a limited pace. So retropulsion small squirts match delivery to that processing rate. When surgery removes this control, the result is cramping, flushing, and lightheadedness after meals, showing exactly what the metering was protecting against. This extra layer belongs to the muscularis externa, not the mucosa or submucosa. The muscularis mucosa remains a single thin sheet just as elsewhere in the gut. Any exam question describing an oblique muscle layer or asking why the stomach churns harder is pointing straight at the stomach. Question 28. A patient who has undergone complete surgical removal of the stomach recovers well, but requires lifelong vitamin B12 injections. Which lost secretion explains this requirement? Your options are A. Intrinsic factor from parietal cells, B. Pepsinogen from chief cells, C. Gastrin from G cells, D. Alkaline mucus from mucus cells. What's your answer? Commit to one before I continue. The correct answer is A. Intrinsic factor from parietal cells. A is correct because parietal cells secrete intrinsic factor, a glycoprotein that binds vitamin B12 and is required for its uptake in the ileum. Without intrinsic factor, the vitamin passes through unabsorbed no matter how much is eaten, which is why the vitamin must be delivered by injection and bypass the gut entirely. B is wrong because pepsinogen becomes pepsin and digests protein, but pancreatic and brush border proteases finish that job perfectly well without it. Protein digestion is not the reason for the injections. C is wrong because gastrin regulates gastric acid and motility. With no stomach present, there is nothing left for gastrin to regulate, and its loss causes no vitamin deficiency. D is wrong because alkaline mucus protects the gastric lining from its own acid. Once the stomach is gone, there is no acid to protect against. The stomach isn't strictly necessary for survival, with one crucial exception. Without it, protein digestion still happens. Acid sterilization is helpful but not indispensable, and storage is just convenient. What can never be replaced is intrinsic factor. Intrinsic factor and hydrochloric acid come from the very same cell, the parietal cell. The proton pump drives hydrogen ions into the lumen against an enormous gradient, making it 1,000,000 times more acidic than blood, while that same cell releases intrinsic factor to carry vitamin B12 toward its absorption site in the ileum. Acid itself accomplishes 3 things. Nothing else in the stomach can. It unfolds proteins for pepsin to attack. It converts pepsinogen into active pepsin and sustains the pH it needs. And it kills most swallowed microorganisms. That's exactly why long-term acid suppression raises the risk of certain gut infections. Keeping these 4 straight is the single highest yield task in this whole area. Chief cells make pepsinogen. Mucus cells make protective mucus. G cells make gastrin. And parietal cells uniquely make both acid and intrinsic factor. A genuinely odd pairing that's the piece most often forgotten. Whenever an exam question mentions gastrectomy with lifelong injections, or megaloblastic anemia with neurological signs, it's pointing straight at the parietal cell and its double product. Question 29. A researcher sampling gastric contents identifies an inactive protein-digesting precursor that converts to its active form only once the luminal pH drops sharply. Which cell released this precursor and what triggers its activation? Your options are: A. Parietal cells release pepsin and intrinsic factor activates it. B. G cells release gastrin and stomach distension activates it. C. Mucus cells release pepsinogen and bicarbonate activates it. D. Chief cells release pepsinogen and hydrochloric acid activates it. Pick one. To trust your gut. Here's your chance to test yourself. The correct answer is D. Chief cells release pepsinogen and hydrochloric acid activates it. D is correct because chief cells secrete pepsinogen in an inactive form, precisely so it cannot digest the cells that produced it. Hydrochloric acid from the neighboring parietal cells converts pepsinogen into active pepsin in the lumen, and pepsin then activates additional pepsinogen in a self-amplifying loop. A is wrong because parietal cells secrete acid and intrinsic factor, not pepsin. Intrinsic factor serves vitamin B12 absorption and has no enzymatic activating role. B is wrong because gastrin is a hormone released into the blood to stimulate secretion and motility. It is not a protein digesting enzyme precursor. C is wrong because mucus cells secrete protective alkaline mucus and bicarbonate raises pH. Raising the pH would prevent pepsin activation rather than cause it. Secreting a protein digesting enzyme inside an organ made of protein is dangerous, so the body has a recurring solution: manufacture the enzyme as an inactive precursor and activate it only after it leaves the cell that made it. Chief cells secrete pepsinogen, a folded blocked precursor, into the gastric pits. Hydrochloric acid from parietal cells cleaves off the blocking segment, exposing active pepsine, and that pepsine then activates more pepsinogen itself, creating a self-amplifying cascade. The molecule is harmless while inside the cell that made it and becomes dangerous only after leaving. So compartmentalization, not chemistry alone, provides the safety. Pepsin also has an unusually narrow working window, functioning best near pH 2 and shutting off as pH rises entering the duodenum. The pancreas uses the identical strategy on a larger scale. Trypsin, chymotrypsin, and carboxypeptidase are all secreted as zymogens. An enteropeptidase in the duodenal brush border converts trypsinogen to trypsin, which then activates the remaining enzymes. Placing that trigger in the intestinal wall means the cascade cannot begin until the enzymes have arrived where they belong. Acute pancreatitis occurs when pancreatic enzymes activate prematurely inside the gland, often from a gallstone blocking outflow, causing the pancreas to digest itself. The severity of that inflammation is a direct measure of how much protection the zymogen strategy normally provides. Question 30. A patient with a gastrin-secreting tumor has severe, treatment-resistant gastric acid production and multiple duodenal ulcers. Which normal action of this hormone accounts for the finding? Your options are: A. It neutralizes duodenal acid directly by stimulating bicarbonate release from the pancreas. B. It stimulates parietal cells to secrete hydrochloric acid and increases gastric motility. C. It relaxes the hepatopancreatic sphincter so that stored bile can enter the duodenum. D. It inhibits gastric emptying so that acid accumulates within the stomach. Which would you go with? Lock it in before the reveal. The correct answer is B. It stimulates parietal cells to secrete hydrochloric acid and increases gastric motility. B is correct because gastrin is the master stimulant of the stomach. Released by G cells in response to distension and to peptides in the lumen, it drives parietal cells to pour out hydrochloric acid, prompts chief cells to release pepsinogen, and increases gastric contractions. A tumor secreting it continuously produces relentless acid output. It is wrong because bicarbonate release in response to duodenal acid is the job of secretin, and its purpose is to neutralize acid rather than to generate it. C is wrong because relaxing the hepatopancreatic sphincter and mobilizing bile are actions of cholecystokinin, released in response to fat and protein reaching the duodenum. D is wrong because slowing gastric emptying is the effect of the duodenal hormones secretin and cholecystokinin. Gastrin increases gastric activity rather than restraining it. A tumor that secretes gastrin non-stop causes relentless acid and ulcers in strange places, and precisely because it removes every brake on the system, it shows us exactly what gastrin normally does. Gastrin comes from G cells scattered in the gastric glands, and it enters the bloodstream like any hormone. Two signals trigger its release: distension of the stomach wall and peptides or amino acids in the lumen, both telling the stomach that protein has arrived and acid is needed. Gastrin acts directly on parietal cells to secrete hydrochloric acid, on chief cells to release pepsinogen, and on gastric muscle to increase motility, turning the whole stomach on as one coordinated unit. Peptides stimulate gastrin, gastrin drives acid and pepsinogen, pepsin makes more peptides, and those peptides call for more gastrin, an unusual positive feedback loop that only ends when falling pH suppresses the G cells. A gastrin-secreting tumor sits outside this feedback loop entirely, so falling pH never shuts it off, and acid keeps flowing until ulcers appear far beyond the stomach itself. Question 31. A patient on long-term proton pump inhibitor therapy has profoundly suppressed gastric acid output. Which set of consequences follows most directly from the missing acid? Your options are A. Impaired emulsification of dietary fat and reduced formation of mites. B. Reduced pancreatic bicarbonate secretion and duodenal ulceration. C. Less denaturation of dietary protein, less activation of pepsin, and less killing of swallowed microbes. D. Loss of intrinsic factor and failure of ion transport across the enterocyte. Don't overthink it, which one feels right. The correct answer is C. Less denaturation of dietary protein, less activation of pepsin, and less killing of swallowed microbes. C is correct because hydrochloric acid does 3 jobs no other gastric secretion can. It unfolds dietary protein so their peptide bonds are exposed. It converts pepsinogen into active pepsin and maintains the low pH. Pepsin requires, and it sterilizes the meal by killing most ingested bacteria. Removing the acid removes all 3 at once. A is wrong because emulsification is performed by bile salts in the duodenum and has nothing to do with gastric acid. Fat handling is largely unaffected. B is wrong because pancreatic bicarbonate is released in response to acid arriving in the duodenum, so less acid means less bicarbonate is needed, not duodenal ulceration. D is wrong because intrinsic factor is a separate parietal cell product with its own secretory pathway. Acid suppression may modestly affect iron and B12 uptake, but the factor itself is still secreted. Proton pump inhibitors are among the most prescribed drugs on earth, and their widespread use has run an accidental experiment on gastric acid. The results tell us exactly which of acid's jobs are essential and which are not. Acid does 3 distinct jobs worth stating separately. It denatures dietary protein, unfolding it so peptide bonds become accessible. It converts pepsinogen into pepsin and sustains the low pH pepsin requires, and sterilizes the meal, killing most swallowed microorganisms. Protein digestion survives acid suppression because pancreatic proteases and brush border peptidases finish the job regardless. But the barrier function fails measurably, with more organisms reaching the small intestine and higher rates of C. difficile and pneumonia. Mineral absorption also suffers, since acid is needed to convert dietary iron to its absorbable form and to dissolve calcium carbonate. Parietal cells pump hydrogen ions into the stomach lumen against a gradient of roughly 1,000,000 to 1, using an ATP-powered proton pump, with chloride following to form hydrochloric acid. Proton pump inhibitors bind that pump irreversibly, so acid production only resumes once new pumps are made. The framing to carry forward. Acid is a preparation and a defense, not a digestive necessity. It readies protein for enzymatic attack and sterilizes the meal. But breaking bonds is pepsin's job, and the pancreas does far more of it. Question 32. An instructor asks why the stomach, which is filled with acid strong enough to strip metal, and an enzyme designed to digest protein, does not digest its own protein-rich wall. Which combination of protections best answers the question? Your options are A. A bicarbonate-rich alkaline mucus coat, tight junctions sealing the epithelial cells, and replacement of the entire lining every few days. B. A thick serosa, the overlying greater omentum, and consistently low pressure within the lumen. C. Continuous dilution by swallowed saliva that keeps the luminal pH near neutral. D. Secretion of pepsin in its active form, only in the region near the pylorus. Got a guess? Lock it in. The correct answer is A. A bicarbonate-rich alkaline mucus coat, tight junctions sealing the epithelial cells, and replacement of the entire lining every few days. A is correct because the gastric mucosal barrier is a layered defense. Alkaline mucus traps bicarbonate right at the cell surface and neutralizes acid where it touches the wall. Tight junctions prevent juice from seeping between cells into deeper tissue. And the epithelium is completely renewed every 3 to 6 days, so damaged cells are discarded before they fail. B is wrong because the serosa and the omentum sit on the outside of the organ and offer no protection to the luminal surface where the acid actually is. C is wrong because saliva is swallowed in small volumes and is quickly overwhelmed. Gastric pH stays near 1.5 to 2 during digestion. D is wrong because pepsin is never secreted in active form anywhere. It is released as pepsinogen precisely so it cannot digest its own cell of origin. The stomach is a protein organ bathed in acid strong enough to strip enamel, yet it doesn't digest itself. That's thanks to a coordinated system of defenses called the gastric mucosal barrier, and understanding it explains exactly when and why peptic ulcers form. 4 defenses work together. First, a bicarbonate-rich mucus layer holds an alkaline microclimate against the cell surface. Second, tight junctions between epithelial cells block acid from leaking into deeper tissue. Third, the entire epithelium turns over every 3 to 6 days. Discarding damaged cells faster than acid can harm them. Fourth, pepsinogen is secreted as an inactive zymogen, only activating after it leaves the cell that made it. The mucus is not just a coating. It traps bicarbonate against the cell surface, creating a steep pH gradient from around 1.5 in the lumen to nearly neutral, right at the epithelium, just microns away. Peptic ulcers arise when this barrier is undermined. Helicobacter pylori burrows into the mucus and degrades it from within, while chronic NSAID use suppresses prostaglandins, the signals that maintain mucus and blood flow. In most cases, acid output is normal. This is a failure of defense, not an overproduction of attack, except in rare gastrin-secreting tumors. Discovering that a bacterium causes most ulcers overturned decades of blame on stress and diet, transforming a lifelong condition into one curable with antibiotics. Question 33. A volunteer fitted with a gastric probe begins secreting gastric juice while a meal is being cooked nearby, well before anything is eaten. Which phase of gastric secretion is this, and which nerve carries the signal? Your options are A. The gastric phase, carried by the myenteric plexus. B. The cephalic phase, carried by the vagus nerve. C. The intestinal phase, carried by the splanchnic nerves. D. The gastric phase, carried by the vagus nerve. Which one is it? Pause the video if you need more time. The correct answer is B. The cephalic phase, carried by the vagus nerve. B is correct because the cephalic phase is named for its origin in the head. Sight, smell, taste, or even the thought of food activates the cerebral cortex and hypothalamus, and the vagus nerve carries that parasympathetic signal to the gastric glands, priming the stomach before food arrives. A is wrong because the gastric phase begins only after food is physically in the stomach, and the myenteric plexus governs motility rather than carrying signals from the brain. C is wrong because the intestinal phase starts when chyme reaches the duodenum, and the splanchnic nerves are sympathetic and inhibitory. Neither element fits a response occurring before eating. D is wrong because the nerve is correct but the phase is wrong. Nothing has entered the stomach, so the gastric phase cannot have begun. In the 1890s, Ivan Pavlov noticed something strange. Dogs who swallowed food never reached the stomach still produce gastric juice just from eating. Something besides physical food was triggering secretion, and it traveled through the vagus nerve. The cephalic phase begins in the head. Sight, smell, taste, or even the thought of food activates the cortex and hypothalamus, which signal through the vagus nerve to the gastric glands. So acid and pepsinogen are already flowing before the first bite is swallowed. This anticipatory strategy shows up throughout the body. Salivation responds to the same learned cues, and glucose-dependent insulinotropic peptide prompts insulin release before blood glucose even rises. In each case, the body spends resources on a prediction, betting that being ready is worth the occasional false alarm. The 3 phases of gastric secretion are named for where the stimulus arises, not where the effect happens. Cephalic means head, gastric means stomach, and intestinal means intestine, but all 3 act on the stomach itself. This is why cutting the vagus nerve, as in old ulcer surgery, wipes out the cephalic phase and slows gastric emptying too. So when an exam stem mentions secretion before eating, a food smell, or the vagus nerve, that's the cephalic phase. Just don't mistake the phase's name for the location of its effect. Question 34. A large protein-rich meal produces the strongest and most sustained portion of gastric secretion during digestion. Which stimuli drive this phase? Your options are A. The sight and smell of food acting through the cerebral cortex and hypothalamus. B. Acidic chyme reaching the duodenum and triggering release of secretin. C. Stretch of the stomach wall combined with peptides in the lumen, acting largely through gastrin. D. Fatty chyme reaching the duodenum and triggering release of cholecystokinin. Take a second. Which answer would you pick? The correct answer is C. Stretch of the stomach wall combined with peptides in the lumen, acting largely through gastrin. C is correct because the gastric phase accounts for most of the secretion during a meal. Stretch receptors register distension, while chemoreceptors register peptides and the rising pH that protein buffering causes. And both stimuli drive G cells to release gastrin, which then amplifies acid and pepsinogen output in a positive feedback loop. A is wrong because sight and smell drive the cephalic phase, which primes the stomach but contributes only a modest fraction of total secretion. B is wrong because acid in the duodenum triggers secretin, whose net effect is to slow the stomach down rather than to sustain its secretion. D is wrong because fat in the duodenum triggers cholecystokinin, which also inhibits gastric activity, so the intestine is not overwhelmed. Most gastric juice made during a meal is secreted in the gastric phase, because this is the one phase where stimulus and target sit in the same organ. Food, receptors, and responding cells are all in the stomach, so the feedback loop is short and powerful. Stretch receptors detect the stomach filling, and chemoreceptors detect peptides and amino acids, signaling that protein has arrived. A third factor is the rise in pH as protein buffers stomach acid, which removes the normal inhibition on gastrin release. Gastrin is the central mediator. It drives parietal cells to make hydrochloric acid, prompts chief cells to release pepsinogen, and increases motility. Histamine amplifies the acid response, and acetylcholine from vagal fibers adds a third stimulatory signal to the same parietal cells. Unusually, this is positive feedback. Peptides stimulate gastrin. Gastrin drives acid and pepsinogen, and pepsin generates more peptides, fueling more gastrin. It escalates only as long as protein remains, then shuts off as substrate runs out, pH falls, and somatostatin adds inhibition. The key comparison is gastric versus intestinal phase. Both involve chyme and hormones, but the gastric phase is stimulatory and driven by gastrin from the stomach, while the intestinal phase is predominantly inhibitory, driven by secretin and cholecystokinin from the duodenum. Direction of effect is what separates them. Question 35. A patient reports feeling uncomfortably full for several hours after a high-fat meal, but notices no such lingering fullness after a carbohydrate meal of the same size. Which mechanism explains the difference? Your options are: A. Fat is absorbed directly across the gastric mucosa and must be processed there before the stomach can empty. B. Fat increases the force of retropulsion, driving chyme backward into the fundus and delaying its exit. C. Fat raises the pH of chyme, which causes the lower esophageal sphincter to close more tightly. D. Fat arriving in the duodenum triggers inhibitory reflexes and hormones that slow gastric emptying. Before I reveal it, which one do you think is right? The correct answer is D. Fat arriving in the duodenum triggers inhibitory reflexes and hormones that slow gastric emptying. D is correct because gastric emptying is mediated by the duodenum, not by the stomach alone. Fat in the duodenum activates the enterogastric reflex and releases secretin and cholecystokinin, both of which slow gastric secretion and emptying so the intestine has time to emulsify and digest the fat. Fatty meals therefore empty the slowest of all meal types. A is wrong because the stomach absorbs very little, and fat is not among the substances it takes up. Fat absorption happens in the small intestine. B is wrong because retropulsion is a normal part of gastric mixing and occurs with every meal. It is not selectively increased by fat content. C is wrong because chyme leaving the stomach is acidic regardless of composition, and lower esophageal sphincter tone does not control the rate of emptying into the duodenum. Why does a fatty meal sit in your stomach for hours while carbs clear in a fraction of that time? The answer isn't in the stomach at all. It's the duodenum downstream that calls the shots. The pyloric sphincter and retropulsion form the baseline metering hardware. Each peristaltic wave pushes chyme against an almost closed pylorus, letting only milliliters through while the rest jets backward for more grinding, guaranteeing a slow trickle no matter how full the stomach is. The duodenum modulates that trickle through the enterogastric reflex, a neural pathway triggered by distension, acid, fat, or concentration. Alongside it, secretin and cholecystokinin add hormonal braking, slowing both gastric secretion and emptying. Fat produces the strongest inhibition because it's the slowest to process, requiring bile salt emulsification before pancreatic lipase can even act. This is why carbohydrate empties fastest, protein is intermediate, and fat is slowest, with a typical mixed meal clearing in 2 to 4 hours. Lose this metering surgically and dumping syndrome results with cramping, flushing, and later hypoglycemia from a rapid insulin surge. Lose it the opposite way through diabetic gastroparesis and delayed. Unpredictable emptying makes insulin dosing much harder. Question 36. A clinician explains that despite being only about 25 centimeters long, one region of the small intestine accomplishes most of the body's chemical digestion. Which region is it, and what makes it so productive? Your options are A. The duodenum, because it receives bile from the liver and gallbladder and enzyme-rich juice from the pancreas. B. The jejunum, because it has the tallest villi and the most thickly muscled wall. C. The ileum, because it recycles bile salts and absorbs vitamin B12. D. The cecum, because material is held there long enough for enzymes to complete their work. What's your answer? Commit to one before I continue. The correct answer is A. The duodenum, because it receives bile from the liver and gallbladder and enzyme-rich juice from the pancreas. A is correct because the duodenum is short but strategically placed. It is where the common bile duct and the main pancreatic duct deliver their contents, so emulsifying bile salts, the full pancreatic enzyme set, and neutralizing bicarbonate all meet the acidic chyme in the same short segment. That convergence is why most chemical digestion is finished there. B is wrong because the jejunum is the primary site of nutrient absorption rather than of digestion. By the time chyme reaches it, most bonds have already been broken. C is wrong because the ileum has genuinely specialized absorptive roles for bile salts and vitamin B12, but these are recovery functions at the end of the line, not bulk digestion. D is wrong because the cecum is part of the large intestine, where digestive enzymes are no longer being secreted and nutrient breakdown is essentially complete. The duodenum is only about 25 centimeters long, roughly the length of an outstretched hand, yet it accomplishes more chemical digestion than any comparable stretch of the tract. That disproportion comes down to what empties into it. Bile from the liver and gallbladder, the full pancreatic enzyme set, and bicarbonate to create the right pH all converge on this one short segment. That's why its shape follows its role, curving in a C around the head of the pancreas, fixed in place because it's retroperitoneal. The common bile duct and main pancreatic duct join into the hepatopancreatic ampulla, which opens at the major duodenal papilla, gated by the hepatopancreatic sphincter. Chyme arrives at pH 2, and bicarbonate plus alkaline mucus from Brunner's glands neutralize it so enzymes can work. Brunner's glands are worth knowing because they're the only submucosal glands in the entire intestine, marking the duodenum as the segment built to neutralize acid. Further along, their absence signals that neutralization is already finished. The three segments run shortest to longest: duodenum, jejunum, and ileum, at roughly 25 centimeters, 2.5 meters, and 3.5 meters. Digestion peaks in the duodenum, where enzymes arrive, while absorption peaks in the jejunum, where surface area and transport machinery are richest, treating the small intestine as one tube loses points on exactly that gap. Question 37. A histologist is asked to rank the small intestine's surface amplifying structures from the largest visible feature down to the smallest. Which order is correct? Your options are A. Villi, plicae circulares, microvilli. B. Microvilli, villi, plicae circulare. C. Plicae circulares, villi, microvilli. D. Rugae, villi, microvilli. Pick one, trust your gut, here's your chance to test yourself. The correct answer is C. Plicae circulares, villi, microvilli. C is correct because the three levels of folding nest inside one another. Plicae circulars are permanent ridges of mucosa and submucosa up to about 1 centimeter tall. Villi are roughly 1 millimeter mucosal projections carpeting those ridges. And microvilli are microscopic extensions of each enterocyte's plasma membrane, forming the brush border. A is wrong because this reverses the two largest levels. Villi sit on top of the plicae circulares, so the plicae are the larger structure. B is wrong because this is the correct sequence read backward, listing the smallest first rather than the largest. D is wrong because rugae are gastric folds, not intestinal ones, and they are temporary rather than permanent. They belong to a different organ entirely. Absorption depends on surface area, not length, and a plain 6-meter tube would never be enough to feed the body. The small intestine solves this by folding its lining at 3 different scales, stacked one on top of the other, packing a tennis court's worth of surface into a tube just 2.5 centimeters wide. The plicae circulars are tall permanent ridges that force chyme to spiral, increasing mixing and contact time. Villi are finger-like projections carpeting those ridges, each containing a capillary network and a central lymphatic vessel called the lacteal. Microvilli are microscopic extensions on every absorptive cell, forming the brush border, where digestive enzymes are anchored directly onto the absorptive surface. Picture zooming in step by step. First the ridges, then the finger-like villi covering them, then the microscopic microvilli covering each cell. Because the enzymes sit right on this absorptive membrane, digestion and absorption happen almost as a single event rather than 2 separate steps. Don't confuse these with rugae, the stomach's folds, which are longitudinal and temporary, existing only to permit expansion. Plicae circulars are transverse and permanent, existing to slow transit instead, opposite purposes in neighboring organs, and a classic exam trap. Celiac disease shows what happens when this architecture is lost. Gluten triggers an immune reaction that flattens the villi, collapsing absorptive surface even though the tube stays intact, causing diarrhea, weight loss, and deficiencies despite adequate eating. Remove gluten and the villi regenerate, proving that surface area, not length, was the limiting factor all along. Question 38. A biopsy of intestinal mucosa shows a single villus containing a dense network of blood capillaries surrounding one central lymphatic vessel. Which absorbed material leaves the intestine through that central vessel? Your options are A. Glucose and galactose after sodium-coupled secondary active transport. B. Triglycerides repackaged as chylomicrons following a fatty meal. C. Amino acids taken up by secondary active transport. D. Water reclaimed by osmosis following the absorption of sodium. Which would you go with? Lock it in before the reveal. The correct answer is B. Triglycerides repackaged as chylomicrons following a fatty meal. B is correct because the central lymphatic vessel of a villus is the lacteal. Fatty acids and monoglycerides are reassembled into triglycerides inside the enterocyte and packaged with cholesterol and protein into chylomicrons, which are too large to enter blood capillaries and must therefore be taken up by the lacteal and carried in lymph. A is wrong because monosaccharides are water-soluble and pass into the blood capillaries of the villus, then travel by the hepatic portal vein to the liver. C is wrong because amino acids follow the same route as sugars, entering the capillary blood and draining into the hepatic portal vein. D is wrong because water is absorbed osmotically into the capillary blood alongside solids. It does not require the lymphatic route. In 1622, Gaspare Celi opened a well-fed dog and found milky white vessels running through its mesentery. He had discovered the lacteals, and the milkiness was chylomicrons, revealing that fat leaves the intestine by a completely different route than everything else. The reason for the separate route is molecular size. Fatty acids and monoglycerides are reassembled inside the enterocyte into triglycerides and packaged into chylomicrons, particles far too large to pass through blood capillary pores, so they enter the lacteal instead, a lymphatic capillary with much larger gaps. Bile salts cluster with fat products in tumor cells that ferry them to the brush border, where the fat diffuses in while bile salts stay behind for reuse in the ileum. Inside the cell, triglycerides reform and pack into chylomicrons, which exit into the lacteal, while sugars and amino acids instead enter the blood capillary. From the lacteal, lymph carries chylomicrons through mesenteric lymphatics to the thoracic duct and into the venous system, bypassing the liver on first pass entirely. Sugars and amino acids, by contrast, drain into the hepatic portal vein and are inspected by the liver first, an asymmetry that matters for lipophilic drug absorption and explains cloudy blood after a fatty meal. When fat absorption fails, steatorrhea and fat-soluble vitamin deficiencies make the mechanism visible. Once you fix the split in mind, water-soluble products get screened by the liver, fat-soluble products bypass it, and most absorption questions resolve without further reasoning. Question 39. An adult develops bloating, cramping, and watery diarrhea within an hour of drinking a glass of milk, yet tolerates aged cheese and yogurt without difficulty. Which defect explains this pattern? Your options are A. Absent pancreatic amylase, so dietary starch is never broken down. B. Absent bile salts, so dietary fat cannot be emulsified before lipase acts. C. Absent enteropeptidase, so trypsinogen is never converted to trypsin. D. Absent brush border lactase. So lactose stays in the lumen, draws in water, and is fermented by colonic bacteria. Don't overthink it. Which one feels right? The correct answer is D. Absent brush border lactase, so lactose stays in the lumen, draws in water, and is fermented by colonic bacteria. D is correct because lactose must be split into glucose and galactose by the brush border enzyme lactase before it can be absorbed. Without lactase, the intact disaccharide remains in the lumen, where it osmotically pulls water in and is fermented by colonic bacteria into gas, producing exactly the pattern of watery stool, bloating, and cramping described. A is wrong because missing amylase would impair starch handling and would produce symptoms after bread, rice, and pasta rather than after milk specifically. B is wrong because missing bile salts causes fatty foul floating stools after fatty meals. Aged cheese is high in fat and would be poorly tolerated, which the patient reports is not the case. C is wrong because missing enteropeptidase blocks activation of the pancreatic proteases and causes protein malabsorption. It has no relationship to milk sugar. Lactase deficiency isn't really a disorder. Most adults worldwide naturally lose lactase after childhood. So declining lactase is the normal human pattern, and lifelong lactase persistence is the evolutionary exception, favored only in populations with long histories of dairy herding. Lactase sits anchored in the brush border membrane, splitting the disaccharide lactose into glucose and galactose right at the point of absorption. Without the enzyme, intact lactose stays trapped in the lumen instead of being absorbed. Unabsorbed lactose is osmotically active, pulling water into the lumen and causing watery diarrhea. It then reaches the colon, where bacteria ferment it into gas and short-chain fatty acids, producing bloating, flatulence, and cramping, all without any inflammation or gut damage. This explains the classic tolerance pattern. Fresh milk is poorly tolerated because it's high in lactose. Aged cheese is fine since most lactose is lost in whey, and yogurt's bacterial cultures supply their own lactase. A patient who reacts to milk but not cheese has essentially diagnosed themselves. Never confuse this with milk allergy. Lactose intolerance is a dose-dependent enzyme deficiency confined to the gut, while milk allergy is an immune response that can trigger systemic reactions and even anaphylaxis. Same food, entirely different stakes. Question 40. Between meals, a motility study records waves of contraction that begin in the stomach and sweep the entire length of the small intestine roughly every 90 to 120 minutes, then stop when the volunteer eats. What is this pattern and what does it accomplish? Your options are A. The migrating motor complex, which sweeps residual debris and bacteria toward the colon between meals. B. Segmentation, which mixes chyme thoroughly with the digestive juices. C. Mass movement, which drives feces forcefully toward the rectum. D. Haustral churning, which agitates residue and promotes water absorption. Got a guess? Lock it in. The correct answer is A. The migrating motor complex, which sweeps residual debris and bacteria toward the colon between meals. A is correct because the migrating motor complex is the interdigestive housekeeping pattern. It starts in the stomach, travels the full small intestine every 90 to 120 minutes, and clears undigested residue, slough cells, and bacteria toward the colon. Eating a meal switches the pattern back to segmentation, which is exactly the behavior described. B is wrong because segmentation is the pattern of the fed state and mixes rather than sweeps. It does not travel the length of the intestine as a single wave. C is wrong because mass movements occur in the colon only a few times per day and move feces, not small intestinal residue. D is wrong because haustral churning is a slow local colonic contraction that agitates residue in the pouches. It is confined to the large intestine. That rumbling in an empty stomach isn't hunger itself. It's the sound of a housekeeping program called the migrating motor complex, sweeping the small intestine clean between meals. The cycle starts in the stomach and travels the length of the small intestine in 3 phases: quiescence, irregular contractions, and then an intense peristaltic burst. Eating a meal abolishes it instantly, switching the intestine over to segmentation. Its job is housekeeping, sweeping residual undigested material, sloughed epithelial cells, mucus, and bacteria toward the colon so nothing accumulates. Segmentation, which dominates during digestion, only mixes material back and forth, so it can't do this clearing job. Motilin, a hormone released during fasting, drives this complex, and when motility is impaired by diabetic neuropathy, scleroderma, or surgery, bacteria accumulate and cause bloating, diarrhea, and malabsorption. Remarkably, the antibiotic erythromycin binds those same motilin receptors, which is why it's used clinically to stimulate gut motility. The exam clue is always timing. Segmentation happens during digestion, while the migrating motor complex happens only between meals, running on a 90 to 120 minute cycle. Question 41. A radiologist describes the colon on an abdominal film as having a distinctive segmented, pouched appearance along its length. Which structural feature creates those pouches? Your options are A. Epiploic appendages tugging the wall into irregular folds. B. The muscle tone of the 3 Teniae coli gathering the wall into Haustra. C. Permanent circular folds of the mucosa and submucosa. D. Villi projecting from the mucosa into the lumen. Which one is it? Pause the video if you need more time. The correct answer is B. The muscle tone of the 3 Teniae coli gathering the wall into Haustra. B is correct because in the large intestine, the longitudinal muscle layer is not a continuous sheet but is gathered into 3 ribbons called the Teniae coli. Because these bands are shorter than the colon itself, their resting tone bunches the wall into the pocket-like sacs known as Haustra, producing the segmented outline seen on imaging. A is wrong because epiploic appendages are small fat-filled tags of visceral peritoneum hanging from the colon surface. They add nothing to wall shape. C is wrong because permanent circular folds are the pleatae circulares of the small intestine. The large intestine does not have them. D is wrong because villi are absorptive projections of the small intestinal mucosa. The colonic mucosa has no villi because nutrient absorption is already complete. The colon's pouched, segmented look on an X-ray comes from a muscular arrangement found nowhere else in the gut. Let's see why that shape appears and what it means for how the colon works. Everywhere else in the alimentary canal, the longitudinal muscle forms one continuous sheet. In the colon, it's gathered into 3 narrow ribbons called the Teniae coli, and because these bands are shorter than the colon itself, their tone bunches the wall into pocket-like sacs called Haustra. The Teniae are the cause. The Haustra are simply the effect of that muscle geometry. 2 extra features complete the colon's exterior. Epiploic appendages are small fat-filled tags of peritoneum whose function is unclear, though one can twist and cause sudden abdominal pain. Meanwhile, Haustral contractions every half hour churn material within these pouches. A slow mixing that helps reclaim water rather than move contents along quickly. The regional path runs from the cecum, up the ascending colon, across the transverse colon, down the descending colon, through the sigmoid colon and into the rectum. The ascending and descending portions are fixed retroperitoneally, while the transverse and sigmoid portions are mobile and intraperitoneal. Remember the relationship, not just the names. Shortened Teniae coli bunch the colon wall, and that bunching produces the Haustra. Understand the cause and you'll never confuse the two under exam pressure. Question 42. A patient with an intestinal infection has frequent watery stools and early signs of dehydration. Which colonic function has been most disrupted? Your options are A. Chemical digestion of the proteins remaining in the residue. B. Recycling of bile salts from the terminal segment of the tract. C. Bacterial fermentation of fiber into short-chain fatty acids. D. Reclamation of water and electrolytes from the residue. Take a second. Which answer would you pick? The correct answer is D. Reclamation of water and electrolytes from the residue. D is correct because the large intestine receives a liquid residue and converts it to semi-solid feces by absorbing water and electrolytes. When infection speeds transit, the contents move through too fast for that reclamation to occur. So water stays in the lumen and leaves as watery stool, carrying the risk of dehydration. A is wrong because chemical digestion is essentially complete before material reaches the colon, and the colon secretes no digestive enzymes. B is wrong because bile salt recycling occurs in the ileum, which is the terminal segment of the small intestine rather than part of the colon. C is wrong because fermentation of fiber by gut bacteria yields short-chain fatty acids and gas. Losing it would not by itself produce dehydrating watery diarrhea. Every day, your digestive tract processes about 9 liters of water. Understanding where that water goes reveals exactly what the colon is built to do. Only 2 liters come from food and drink. The other 7 are secreted internally as saliva, gastric juice, bile, and more. The small intestine reclaims most of it, leaving the colon to recover over 90% of what remains. So barely 100 milliliters escapes in stool. The mechanism is simple. Sodium gets pumped out of the colon actively, chloride follows it, and water simply follows the osmotic gradient created by both. Water and electrolytes move together, never separately. Stool consistency is really just a readout of transit time. Move too fast and water never gets absorbed, causing diarrhea. Move too slow and too much water is pulled out, causing constipation. One variable, 2 opposite results. Exam questions exploit this distinction deliberately. Ask which organ absorbs the greater volume of water, and the answer is the small intestine. Ask which organ's failure turns stool watery, and the answer is the colon. Question 43. A patient completing a prolonged course of broad-spectrum antibiotics develops easy bruising and a prolonged clotting time, with normal liver function tests and no dietary change. Which loss best explains this finding? Your options are A. Loss of bile salts needed to emulsify dietary fat. B. Loss of intrinsic factor needed for vitamin B12 absorption. C. Loss of colonic bacteria that synthesize vitamin K. D. Loss of pancreatic proteases needed to digest dietary clotting proteins. Before I reveal it, which one do you think is right? The correct answer is C. Loss of colonic bacteria that synthesize vitamin K. C is correct because the resident bacteria of the large intestine synthesize vitamin K and several B vitamins, which the colon then absorbs. Vitamin K is required for the liver to make functional clotting factors, so wiping out the microbiota with broad-spectrum antibiotics can produce a bleeding tendency even when the liver itself is healthy. A is wrong because loss of bile salts causes fat malabsorption with greasy stools. It can secondarily reduce vitamin K uptake, but antibiotics do not remove bile salts. B is wrong because intrinsic factor deficiency impairs vitamin B12 absorption and causes anemia and neurologic changes, not a clotting defect. D is wrong because clotting factors are synthesized by the liver from amino acids rather than absorbed intact from food, so protease loss would not explain the bleeding. Forget the idea of gut bacteria as passengers along for the ride. They perform metabolic work our own genome cannot do, and the relationship is mutualistic, not merely tolerated. The microbiota functions less like contamination and more like an organ in its own right. The colonic bacteria run 3 essential jobs. First, fermentation, breaking down fiber human enzymes cannot touch. Second, vitamin synthesis, producing vitamin K and B vitamins. Third, competitive exclusion, crowding out pathogens by occupying every available niche. Bacteria ferment fiber into short-chain fatty acids, acetate, propionate, and butyrate. Butyrate is especially remarkable. It is the preferred fuel of the very colon cells that host these bacteria. The lining of the colon is literally fed by its own microbiome. Broad-spectrum antibiotics can suppress vitamin K producing bacteria enough to prolong clotting time in a patient with a healthy liver. They can also let Clostridioides difficile expand and cause severe colitis. The best treatment for recurrent cases: fecal microbiota transplantation. Doesn't kill an organism, it restores an ecosystem. The colon is not simply where water gets removed. It runs a fermentation chamber, harvests vitamins we cannot make ourselves, and maintains a living barrier against infection, an organ built entirely from bacteria we once dismissed as passengers. Question 44. An adult feels the urge to defecate during a long meeting and is able to postpone it comfortably until the meeting ends. Which mechanism makes this possible? Your options are: A. The internal anal sphincter is held contracted under conscious control. B. The external anal sphincter is skeletal muscle and can be voluntarily kept closed. C. The rectal stretch receptors can be voluntarily switched off. D. Mass movements are suppressed on demand by the gastrocolic reflex. What's your answer? Commit to one before I continue. The correct answer is B. The external anal sphincter is skeletal muscle and can be voluntarily kept closed. B is correct because the defecation reflex relaxes the internal anal sphincter involuntarily once the rectum is stretched, but the external anal sphincter is skeletal muscle under conscious somatic control. Keeping it contracted defers defecation, and the reflex then subsides until the next mass movement pushes more feces into the rectum. A is wrong because the internal anal sphincter is smooth muscle and relaxes reflexively. It cannot be commanded to stay shut. C is wrong because stretch receptors fire mechanically in response to rectal distension. Their signaling cannot be consciously silenced. D is wrong because the gastrocolic reflex triggers mass movements after the stomach fills rather than suppressing them, and it is not under voluntary control. Continence is a control problem. The rectum must empty completely when it's appropriate, and stay closed when it isn't. Neither pure reflex nor pure willpower can solve that alone. So the body splits the job between 2 sphincters. The internal anal sphincter is smooth muscle, entirely involuntary, controlled by a parasympathetic reflex through the sacral spinal cord. The external anal sphincter is skeletal muscle, innervated by somatic motor neurons, and stays under conscious control, giving the brain final veto power. A mass movement pushes feces into the rectum, stretch receptors fire, and a sacral reflex relaxes the internal sphincter automatically. At that instant, only the external sphincter is holding the line, and you consciously choose whether to release it or clamp down and wait. Mass movements are powerful, infrequent colon contractions, often set off after meals by the gastrocolic reflex, which explains the classic post-breakfast urge. Straining via the Valsalva maneuver helps expel stool, but also raises intrathoracic pressure, impeding venous return and risking arrhythmia or syncope, while stool softeners follow a heart attack. Hold on to this. The internal sphincter relaxes automatically and cannot be commanded, while the external sphincter is the sole voluntary checkpoint. Spinal cord injury above the sacral level proves the point exactly. The reflex still empties the rectum, but conscious control is gone. Question 45. A surgeon resects the junction where the small intestine empties into the large intestine. Which structure has been removed and what did it normally prevent? Your options are A. The ileocecal valve, which prevents backflow of bacteria-laden colonic contents into the ileum. B. The pyloric sphincter, which prevents backflow of chyme into the stomach. C. The hepatopancreatic sphincter, which prevents reflux of duodenal contents into the bile duct. D. The internal anal sphincter, which prevents involuntary leakage of stool. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. The ileocecal valve, which prevents backflow of bacteria-laden colonic contents into the ileum. Is correct because the ileocecal valve guards the junction between the ileum and the cecum. It meters the passage of residue into the large intestine and, just as importantly, blocks the heavily colonized colonic contents from washing back into the relatively sparse bacterial environment of the ileum. B is wrong because the pyloric sphincter sits between the stomach and duodenum, far upstream of the ileocecal junction. C is wrong because the hepatopancreatic sphincter controls the release of bile and pancreatic juice into the duodenum through the major duodenal papilla. D is wrong because the internal anal sphincter is at the very end of the tract, guarding the anal canal rather than the ileocecal junction. At the junction of small and large intestine sits a gate that must work in both directions, and just beyond it hangs a small tube whose geometry explains a common surgical emergency. The ileum holds few bacteria and still absorbs nutrients, while the cecum opens into a colon teeming with trillions of organisms. The valve meters residue forward at a manageable pace, blocks colonic contents from washing backward, and opens or closes based on distension in the ileum and cecum, plus signals from stomach filling. The cecum is a blind pouch, and hanging from it is the appendix, a narrow worm-shaped tube of lymphoid tissue once dismissed as vestigial, but now viewed as a reservoir that can help recolonize the colon with beneficial bacteria. The appendix's narrow lumen and single opening make it prone to obstruction, which traps secretions, raises pressure, compromises blood supply, and lets bacteria invade the wall. Pain starts as vague periumbilical discomfort from visceral afferents, then migrates and sharpens to the right lower quadrant as the inflamed appendix irritates the somatically innervated parietal peritoneum. A ruptured appendix floods the sterile peritoneal cavity with bacteria across an enormous absorptive surface, making appendicitis a surgical emergency driven entirely by the anatomy of that space. Question 46. A student states confidently that bile digests fat. Which correction is accurate? Your options are A. Bile digests fat, but only after pancreatic lipase activates it inside the duodenum. B. Bile digests fat in the stomach rather than in the small intestine. C. Bile digests fat by hydrolyzing each triglyceride into fatty acids and glycerol. D. Bile contains no enzymes at all and instead physically disperses fat globules into tiny droplets so that lipase can work faster. Which would you go with? Lock it in before the reveal. The correct answer is D. Bile contains no enzymes at all and instead physically disperses fat globules into tiny droplets so that lipase can work faster. D is correct because bile is an emulsifier, not an enzyme solution. Bile salts break large fat globules into thousands of small droplets, which multiplies the surface area available to pancreatic lipase without breaking a single chemical bond. The distinction between a physical and a chemical step is the point being tested. A is wrong because bile is never activated into an enzyme. Lipase and bile salts cooperate, but bile has no latent catalytic capability. B is wrong because only a small amount of fat digestion occurs in the stomach through gastric and lingual lipase, and bile is delivered to the duodenum rather than the stomach. C is wrong because hydrolysis of triglycerides is the work of pancreatic lipase, and its products are 2 fatty acids and a monoglyceride rather than free glycerol. Bile is one of the most misunderstood substances in digestion. It contains no digestive enzymes, breaks no chemical bonds, and never touches a triglyceride's structure. What bile does is physical, not chemical, and that distinction changes everything about how fat digestion actually works. Fat isn't water-soluble, so it clumps into large globules in the intestine. Pancreatic lipase can only work at the surface where water meets fat. So bile salts shatter that globule into thousands of droplets, multiplying surface area enormously without breaking a single bond. Bile salts pull this off because they're amphipathic, built from cholesterol with one water-attracting face and one fat-attracting face. They coat each droplet water facing side outward, which keeps droplets from merging back together. Emulsification is both breaking apart and stabilizing, and the stabilizing is what makes it last. Bile also runs a second unrelated job, excretion. Bilirubin, the pigment from broken down red blood cells, has no digestive role at all. Excess cholesterol and processed drugs and toxins leave the body the same way, sharing belly's duct purely by convenience, not function. The gallbladder simply stores and concentrates this bile until a fatty meal calls for it, and when concentration goes too far, gallstones can form. But the core exam framing stays simple. Bile is a detergent, not an enzyme, dispersing fat so lipase can chemically break it down. Question 47. A fatty meal arrives in the duodenum. The gallbladder contracts and expels its stored bile. The pancreas releases its digestive enzymes, and the sphincter guarding the duodenal papilla relaxes. Which hormone coordinates this entire response? Your options are A. Gastrin, B. Secretin, C. Cholecystokinin, D. Glucose-dependent insulinotropic peptide. Don't overthink it. Which one feels right? The correct answer is C. Cholecystokinin. C is correct because cholecystokinin is released by our cells of the duodenum in response to fatty and protein-rich chyme, and its name literally describes causing the gallbladder to move. It contracts the gallbladder, stimulates the pancreatic axini to release enzymes, relaxes the hepatopancreatic sphincter, and slows gastric emptying, which is the complete package described. A is wrong because gastrin is released by gastric G cells and acts on the stomach, driving acid, pepsinogen, and motility. It does not mobilize bile. B is wrong because secretin responds to acid rather than the fat, and its main action is to call for bicarbonate rather than for bile and enzymes. D is wrong because glucose-dependent insulinotropic peptide prompts insulin release ahead of glucose absorption and mildly restrains the stomach. It does not empty the gallbladder. Cholecystokinin literally means bile sac movement, and that name says it all. It's the hormone that mobilizes the entire digestive response to a fatty meal, released by duodenal cells when fatty. Protein-rich chyme arrives from the stomach, with fat being the stronger trigger. 4 effects follow, and they all serve one goal. The gallbladder contracts to expel bile. The pancreas releases its enzymes. The hepatopancreatic sphincter opens so both can reach the duodenum, and gastric emptying slows so the stomach doesn't overwhelm the system with more fat. Picture fat arriving in the duodenum, it triggers CCK release, which reaches back to squeeze bile from the gallbladder, pull enzymes from the pancreas, and pry open the shared duct so both fluids can flow in to meet the fat that's waiting. CCK also signals the brain to produce satiety, linking fat's arrival to the decision to stop eating. And when a gallstone blocks the cystic duct, CCK still does its job, contracting hard against the obstruction and causing the pain of biliary colic. Keep it separate from secretin. Acid calls for bicarbonate buffer, while fat and protein call for bile and enzymes. Question 48. Acidic chyme arrives in the duodenum, and the pancreas responds by pouring out a watery alkaline secretion. Which hormone drives that response, and what problem does it solve? Your options are secretin, which triggers bicarbonate release to neutralize the acid and restore the near-neutral pH that pancreatic and brush border enzymes require. B. Cholecystokinin, which triggers enzyme release so the arriving nutrients can be digested. C. Gastrin, which triggers further acid release so protein digestion can continue downstream. D. Glucose-dependent insulinotropic peptide, which triggers insulin release before glucose is absorbed. Got a guess? Lock it in. The correct answer is A. Secretin, which triggers bicarbonate release to neutralize the acid and restore the near-neutral pH that pancreatic and brush border enzymes require. A is correct because secretin is released by S cells of the duodenum specifically in response to acid, and it directs the pancreas and liver to secrete bicarbonate. That buffering lifts duodenal pH into the neutral range where pancreatic and brush border enzymes work, and it protects the intestinal lining from acid injury. B is wrong because cholecystokinin responds to fat and protein rather than acid, and it delivers enzymes rather than buffer. C is wrong because more acid is the opposite of what an already acidic duodenum needs, and gastrin acts on the stomach rather than the pancreas. D is wrong because insulin release prepares tissues for incoming glucose and does nothing to correct duodenal pH. In 1902, Bayliss and Starling found that acid in the duodenum triggered pancreatic secretion even after every nerve was cut. Something traveled through the blood instead. They named it secretin and coined the word hormone to describe it. Chyme leaving the stomach carries a pH near 2, but pancreatic and brush border enzymes are inactivated below roughly pH 6. Unless that acid is neutralized within moments, digestion simply stops at the duodenum. S cells in the duodenal mucosa sense falling pH and release secretin into the blood. Secretin then signals the pancreatic duct cells and liver to pour out a watery, bicarbonate-rich fluid that buffers the acid and restores a working pH. Secretin also inhibits gastric secretion and slows gastric emptying, restricting how much more acid can arrive. Meanwhile, actinar cells make the enzyme-rich secretion under cholecystokinin, while duct and centroactinar cells make the bicarbonate-rich fluid under secretin, two hormones matched to two separate problems. Brunner's glands add extra alkaline mucus, marking the duodenum as the segment built specifically to handle acid. The broader lesson: the duodenum senses what has arrived and summons the exact tool required. So each hormone follows logically from the situation rather than needing separate memorization. Question 49. The pancreatic proteases are delivered into the duodenum in inactive form and become active only after they arrive there. Which enzyme performs the first activation step, and where does it come from? Your options are A. Trypsin, which the pancreatic acini secrete in fully active form. B. Enteropeptidase from the duodenal brush border, which converts trypsinogen into trypsin. C. Pepsin, which is carried into the duodenum along with the chyme. D. Hydrochloric acid, which is delivered to the duodenum from the stomach. Which one is it? Pause the video if you need more time. The correct answer is B. Enteropeptidase from the duodenal brush border, which converts trypsinogen into trypsin. B is correct because enteropeptidase, also called enterokinase, is anchored in the duodenal brush border and cleaves trypsinogen into active trypsin. Trypsin then activates chymotrypsinogen and procarboxypeptidase. So a single membrane-bound trigger located safely outside the pancreas starts the whole protease cascade. A is wrong because if trypsin was secreted active, it would digest the pancreas on the way out. That premature activation is precisely what happens in acute pancreatitis. C is wrong because pepsin is a gastric protease that is inactivated as the pH rises in the duodenum. It plays no role in activating pancreatic zymogens. D is wrong because acid activates pepsinogen in the stomach, but in the duodenum it is neutralized by bicarbonate and would inactivate the pancreatic enzymes rather than turn them on. The pancreas is really two organs sharing one structure, and its two roles have almost nothing to do with each other. Keeping them separate in your mind prevents a lot of exam confusion. The exocrine pancreas is the body's most complete digestive gland, producing enzymes for every nutrient class. Amylase handles carbohydrate, lipase handles fat, trypsin and chymotrypsin handle protein, and ribonuclease and deoxyribonuclease handle nucleic acids. The proteases leave the pancreas as harmless zymogens. Enteropeptidase, sitting in the duodenum's brush border, converts trypsinogen into trypsin, which then activates chymotrypsinogen and procarboxypeptidase. So the cascade can only begin once the enzymes are safely outside the gland. If enzymes activate too early, the pancreas digests itself, causing severe pain and inflammation. Gallstones and alcohol are the leading causes, and because the bile duct and pancreatic duct merge at the hepatopancreatic ampulla, one stone can block both, producing jaundice and pancreatitis together. Remember the endocrine side too. Beta cells release insulin, alpha cells release glucagon, and losing beta cells turns this digestive gland into the source of diabetes. Whenever a question mentions duct-based and blood-based secretion together, it's pointing straight at the pancreas. Question 50. After a mixed meal, a researcher samples lymph from the thoracic duct and finds it milky white, while blood drawn from the hepatic portal vein is clear but rich in dissolved nutrients. Which explanation fits these findings? Your options are: A. Amino acids are packaged into chylomicrons and enter the lymph, while fats dissolve directly into the portal blood. B. All absorbed nutrients enter the lymph first and reach the blood only after passing through the liver. C. Fats are packaged as chylomicrons too large to enter blood capillaries and so enter the lacteals, while sugars and amino acids enter the capillaries and drain to the liver. D. Fats are absorbed exclusively in the ileum, a region where blood capillaries are absent from the villi. Take a second. Which answer would you pick? The correct answer is C. Fats are packaged as chylomicrons too large to enter blood capillaries and so enter the lacteals, while sugars and amino acids enter the capillaries and drain to the liver. C is correct because absorption splits by solubility. Monosaccharides and amino acids are water soluble and pass into the capillary bed of each villus, then travel by the hepatic portal vein to the liver. Fatty acids and monoglycerides are reassembled into triglycerides and wrapped into chylomicrons that are too bulky for capillary pores, so they enter the lacteal and turn the lymph milky. A is wrong because this reverses the two roots. Amino acids are water soluble and never require chylomicron packaging. B is wrong because only fat-derived material takes the lymphatic route, and that route bypasses the liver on first pass by emptying into the venous system at the base of the neck. D is wrong because every villus along the small intestine contains both capillaries and a lacteal, and fat absorption is not confined to the ileum. Absorption seems simple, but the mechanism behind each nutrient is very specific, and that specificity is exactly what exam questions test. Glucose and galactose are pulled in by the sodium-glucose linked transporter, riding sodium's coattails, while a separate sodium-potassium pump spends ATP to keep that sodium gradient charged. Fructose, by contrast, uses a different carrier and simple facilitated diffusion with no sodium coupling, which is why it moves slower and can overwhelm the gut. Sugars and amino acids are water-soluble, so they drain into the hepatic portal vein and pass through the liver first. Fat is the exception. It's packaged into chylomicrons too large for capillaries, picked up by the lacteal, and sent through the thoracic duct straight into general circulation, skipping the liver entirely. Water absorption is passive, simply following sodium osmotically, which is exactly why oral rehydration therapy pairs glucose with sodium to drag water along with it. Vitamins split the same way. Most water-soluble ones absorb along the small intestine, except B12, which needs intrinsic factor and only absorbs in the ileum, while fat-soluble vitamins hitch a ride with dietary fat. Water-soluble nutrients travel to the blood and then the liver, while fat-soluble products travel to the lymph and then general circulation. Apply those two rules and nearly every absorption question resolves itself. That wraps up our question and answer review for Domain 1, the digestive system. If you'd like to keep practicing what we covered today, be sure to visit our website. You'll find hundreds of free practice questions there, plus complete study guides designed to help reinforce everything we've gone over in this lesson. Just check the link down in the description below to get started, and happy studying. Subscribe so you don't miss our next domain review, and good luck on your Anatomy and Physiology 2 exam.